Hello, everybody. Welcome, welcome. Please take your seats. It's such a pleasure to see you all today at this amazing event that we put on every year, and it's all about you guys, right? It's not about anybody else, it's about you and your wonderful colleagues who are going to give some talks today on their work in the labs they've been in. So today's sessions, we're going to have an afternoon session, and a morning session, and an afternoon session with trainee speakers. Please do attend the poster session, right? It's between 12 and 1:30 today. You will see your colleagues energized about their work, and you need to go and listen to all of those little tiny talks that they're going to give, although they might be also elaborate. Who knows? We're going to have presentations by faculty from here at UCSF and from outside of UCSF. Faculty member from University of Kentucky College of Dentistry is here today, Luciana Macallon-Shadox. And welcome to you. And we'll have a presentation on a spotlight on clinical excellence by Diana Nguyen. And then this afternoon is the Mentor of the Year, which is being awarded to Jeff Bush. So please do attend all of those, and there's going to be a raffle. Okay, there's a raffle. So if you don't come to that, you don't win. I'm going to win it. Okay, thank you so much, Mike.
Thanks, Sarah. Good morning. I'd like to thank everyone for coming to Research and Clinical Excellence Day. So, I'm delighted to be here today. This is the 22nd year that we've held Research and Clinical Excellence Day, and it's an enduring tradition that we're proud of. It's one of my favorite events of the year, and it's actually one of my favorite times of the year. We have Research and Clinical Excellence Day, and then later in the month we have the Halloween celebration. It just got me thinking, why don't mummies go on vacation in October? They're afraid they'll unwind. Okay, today is, thank you. Today is our chance to unwind a little bit. And, Research and Clinical Excellence Day celebrates what is unique and special about UCSF School of Dentistry. And this event is really dedicated to that spirit of discovery that really is throughout our community. It's an incredible science that comes out of the passion. And today we recognize scientists who discover, and of course, one of the keys is we recognize the heart of our mission, and that's the bright and ever-curious students who come to master science and combine that with compassionate care to make a difference in our communities. The talks you'll hear today are invaluable. World-class scientists will share their pursuits and their findings with us, and we'll learn so much. This is why I'm so happy about this day. I always learn an incredible amount throughout the day. And there's something else that I think holds tremendous value: just being together in our community of clinicians and researchers. What I've experienced at Research and Clinical Excellence Day and many other research meetings is there's tremendous value in the cross-conversation. So those that happen at the poster session and in between the talks. So today at lunch, you may have a conversation with someone. At the reception, at the end of the day, you may have another one. And those conversations plant a seed in someone's mind that may produce something new. It may become forward with a new thought of how cells interact, how they organize into organs. It may come forward with even a new treatment for patients. But all of them begin with what you're here to hear about, and that's the devotion to discovery. So I want to thank everyone for being here today, to come with us, to hear this exciting lineup of speakers, and those who came to learn today. Thank you each for being here and contributing to this.
Okay, everyone, let's get started. Please, everyone, get seated. First, thank you so much, Dr. Shadox, for the insightful and inspiring presentation. We will now move on the student presentation. We have series of very interesting presentation by our students. There is an opportunity for them to share their work, demonstrate their critical thinking, and engage in a scholarly discussion. And also we have 10 minutes for each student, about 7-minute presentation, and hopefully 2 to 3 minutes for questions. And our first presenter is Dylan Holder, mentor Dr. Chaffee, and the title of presentation is Substance Use and Mental Health Patterns Among LGBT's Adolescents.
Okay, how's this sound? Cool. All right, hello everyone. My name is Dylan Holder. I am a D3, and I'll be talking about something I'm very passionate about, which is substance use and mental health patterns among LGBTQ adolescents. Quickly, I'd like to thank the D2 Research Fellowship Project for making this project possible, as well as the California Department of Public Health. I'd also like to thank our UCSF team and the team at the California Tobacco Prevention Program. I'd also like to give a really big, huge thank you to my mentor, Dr. Chaffee, for all of his help and support throughout the year. So as everyone in this room being oral health, either providers, clinicians, researchers, we all are more than well aware that there is oral health concerns when it comes to substance use. Especially when we're looking at nicotine and cannabis specifically, there is 3 different causes of concern. One is caries, periodontal disease, and oral cancer. And so because of this, I wanted to identify if there's at-risk populations that might be more likely to use substances and consequently have more long-term oral health concerns. And additionally, I wanted to look within younger generations specifically because there's been a rapid gaining popularity amongst new tobacco and nicotine products. And so being able to try and identify these trends within that population and hopefully prevent long-term substance use and consequent long-term detrimental oral health concerns would be ideal. So 2 of the substance use indicators that I wanted to look at specifically was 1, poor mental health, and then secondly, LGBTQ status. And so for poor mental health, it's been well researched that this compounds risk of substance use, and there's also a lot of evidence to indicate that there's higher nicotine and cannabis use in LGBTQ plus individuals. So I wanted to confirm these findings within our own data set, as well as look at them simultaneously together. And the ultimate goal for this is to better understand how to care for these at-risk populations in order to hopefully be able to improve our ability to provide for them effectively, as well as advocate for them and their unique needs in these populations. And so in order to do that, we did 2 different parts for our aims. First, we wanted to quantify associations between poor mental health and substance use among LGBTQ adolescents. Then after finding these trends on the raw data, we then wanted to converse with queer young adults and ask them about these trends and their own personal experiences to try and offer better context to these findings. So first, we wanted to examine how perceptions within LGBTQ community and coming out experience potentially relate to nicotine and cannabis use. So starting first with our quantitative methods, we utilized the Teens Nicotine Tobacco Project, and we used data from 3 different years. This is an online panel survey of California adolescents, and this was a large questionnaire that asked questions about a variety of substances, as well as the frequency of substance use, and as well as different identity questions. We had about 13,000 participants. This is a cross-sectional design, and then we weighted the data accordingly to represent California's population. We wanted to specifically look at quantifying past 30-day substance use, meaning if an individual noted that they used a substance within the past 30 days, and we wanted to focus in specifically on alcohol, e-cigarettes, and cannabis. The 2 variables of interest for us were LGBTQ+, as well as a self-reported mental health variable. We noted individuals as having poor mental health if they self-reported having poor or fair mental health, and then we reported them as good mental health if they self-reported having good, very good, or excellent mental health. So jumping into our findings, first we found, with looking at the prevalence of past 30-day substance use for LGBTQ+ individuals compared to non-LGBTQ+ individuals, we found that there was higher prevalence of past 30-day substance use in LGBTQ individuals, and we can see that alcohol is the highest substance use amongst these 3. And then doing the same, but this time with mental health as the variable of interest, we found that there was about twice the prevalence of substance use in poor mental health individuals compared to good mental health individuals. And once again, we saw that alcohol had the highest substance use, or highest prevalence of substance use. And then we wanted to dive into LGBTQ identity and poor mental health. And I think this would be my biggest takeaway from today. I think this is a really striking finding, is that within LGBTQ individuals, we found there's 3 times the prevalence as compared to non-LGBTQ individuals. And so I think this is really representative that this poor mental health within this population is not an individualized thing, is that there's something going on socially or systematically that is causing these quite a higher substantial prevalence of poor mental health within this population. So then we put all this information together and we looked at them simultaneously. And what we found is, regardless of what substance we looked at, either it was alcohol, e-cigarettes, or cannabis, consistently the LGBTQ individuals with poor mental health had the highest substance use prevalence. And then once again, alcohol showing that with LGBTQ identity and poor mental health being the highest prevalence of substance use. Presenting this information in a different way, we then wanted to adjust for specific confounders, and we wanted to look for a specific association of poor mental health with substance use. And what we found is that for all 3 substances, there's about double the odds of substance use for individuals with poor mental health, independent of their LGBTQ identity. And then similarly, but this time looking at associations of LGBTQ identity with substance use, we found that alcohol and e-cigarettes were not statistically significant, but that LGBTQ individuals had nearly double the odds of cannabis use, independent of their mental health status. So now that we found all this quantitative findings, we then wanted to dive into our qualitative aspect. In order to do this, we utilized the T&T focus groups. This is comprised of 3 groups of 13 individuals aged 17 through 22. These were semi-structured discussions, and we wanted to analyze their perceptions of substance use, stress, and coming out experiences. I personally was really intrigued about researching more coming out experiences because that's a uniquely queer experience that is oftentimes associated with very high stress and uncertainty. And then from these conversations, we wanted to explore qualitative themes that we found. And ultimately, we found 3 major themes. First being the normalization of substance use within LGBTQ identity and culture. One individual said that I think drug use, and especially drug abuse, is very ingrained in LGBTQ culture, which I think really showcases, again, just how normal it is within these different queer spaces to engage in substance use with one another. And then additionally, we found that negative coming out experiences are potential triggers for substance use. However, not all participants noted that their coming out experience was interlinked with their substance use. However, individuals that said that they had a or have had a negative coming out experience or experienced homophobia after coming out, that was intertwined with their substance use, whether they're starting it or using it in a different way. And then lastly, we found that poor mental health was a key driver of substance use. Again, this is well researched that if you have poor mental health, a lot of times you utilize substances as a way of trying to cope with that, whether it being anxiety, depression, or other mental health disorders as well. So completely wrapping up, what we found is that LGBTQ individuals and those with poor mental health had the highest prevalence of substance use. We found that when looking at LGBTQ individuals, they had 3 times the prevalence of poor mental health compared to non-LGBTQ individuals. And then LGBTQ plus related stress, social norms, and shared experience influence substance use behaviors. And the ultimate goal from this finding is to be able to try and offer more targeted, culturally affirming interventions within these populations, and hopes of being able to address these disparities in behavioral and oral health outcomes. Again, especially noting the different oral health implications of substance use. And that is my presentation. Thank you so much. Are there any questions? Yes, up there. Yeah.
Hi, great presentation. Were there any other qualitative themes or findings that you found that were not specific to queer or LGBTQ plus identity?
I think one other thing that we found was that within adolescents with vaping was a big thing, a conversation within the qualitative. They talked about how it's very like a socially driven activity, and that there's almost like that peer pressure aspect, and like also the sense of like popularity associated with vaping, but not a lot of the participants really connect that necessarily with their LGBTQ identity, which is why I didn't necessarily specify that, but that was a consistent theme that was brought up amongst all 3 focus groups. Yeah, thank you. Yes?
Very nice presentation. In your quantitative analysis, how do you define substance use? So it's a binary variable. What's the threshold dose? And does the data set enable you to do a dose-related analysis? In other words, do any of these substances, are they categorized as ordinal variables?
Yeah, so we had different types of questions. So we decided to focus in on past 30-day use, but there was also questions of, have you ever utilized this substance? Do you use them frequently? Those types of questions. I don't believe that we had like a consistent, like how long. I think the past was like 30 days. I don't think we had before that for those specific data, yeah. Oh, sorry, yes. Oh, I misinterpreted your question. Yes, that was one of the questions as well, so the frequency. So there was specific questions to ask about how many days within the past 3 days did you use substances? And then I believe we capped it at like 20 plus days or then from in there, yeah. So we looked into all of that as well, but we thought the easiest variable would be the past 30-day substance use. Yes. Okay, all right, thank you.
Thank you so much, Dylan. That was excellent. The next presenter is Jay Kim, mentor Dr. Hong, and the title of presentation is P75NTR preserves condylar architecture and cellular population in temporomandibular joint.
All right. Hello, everyone. My name is Jay Kim. I'm a third-year dental student. My mentor was Dr. Hong. Let's dive right in. So now, I think everyone here would agree that having any type of jaw pain, clicking, or even locking of jaw is not a pleasant experience. I once had a patient myself whose jaw got locked during the dental procedure, and my faculty and I had to manually unlock the jaw for them, which was quite the learning experience. These type of disorders in our temporomandibular joint, or the TMJ, impairs our daily functions like speaking and chewing. What's surprising is that TMJ issues are very common, affecting 34% of the world population. Despite this huge number, though, our current therapeutic options are very limited. It's more of a palliative care and pain management rather than actual cure. So we thought, is there any way to tackle this inherent cause of the problem down to the cellular level? And potentially stop the degeneration of the TMJ and regenerate the lost tissue. That's why we came to focus on this novel receptor, P75NTR, or P75 in short. P75 is a key neurotrophic receptor, used to be more well known for its role in the nervous system, but recent studies revealed its new role in cartilage homeostasis. It's also expressed very highly across all TMJ components, so it's a good candidate for investigating potential therapeutic targets. So our previous work showed that global knockout of P75 leads to TMJ degenerative changes, like in figure A, and reduced condyle volume, like in figure B. However, P75's specific role in cartilage is still unclear, and we need to rule out the potential systemic effect, like on the nervous system, from the global knockout model. So that led to the specific aims of my project. We want to understand what P75 does in the TMJ cartilage through two main experiments. So first, we deleted P75 gene, specifically in cartilage cells in vivo, using a system called aggregant-CRE, and then we used stem cells from mouse and humans to study how P75 affects cartilage differentiation. So our ultimate goal is to achieve better understanding of mechanisms and targets for future TMD therapies. So before I go in a little deeper about methods and results, I wanted to briefly touch on the anatomy of the TMJ to show you which anatomic landmarks I was looking for in my experiments. So this is a sagittal section of mouse TMJ, and as you can see, there's a fossa on the top, disc in the middle, mandibular condyle and at the bottom, and then it has a thin layer of cartilage on the surface, which has three distinct zones, which is superficial zones, proliferative zone, and deep zone. So for my project, I started with injecting tamoxifen to conditionally knock out P75 and cartilage of mice. I injected at postnatal day 7 and maintained for 5 days. Once injected, tamoxifen activates the CRE enzyme, which then binds to the lock speed site and knocks out P75 on the aggregant promoter, which is chondrocyte specific. Then I perform cell lineage tracing, which essentially looks at the expression of this fluorescent protein called TD tomato, which helps us visualize where CRE activity is. So the merged photo of TD tomato with DAPI shows that CRE activities is localized to condylar cartilage of the TD tomato mice, confirming the targeting of cartilage. Next, I harvested TMJ tissue from the 6 weeks old conditional knockout mice and control mice. Paraffin sections were used for histological analysis and cryosection for immunofluorescence analysis. So the immunofluorescence analysis shows that there's no signal in the condylar cartilage of knockout mice compared to control, which confirmed the successful deletion of P75 in cartilage. Next, histological analysis on the stain samples showed that there was a statistically significant reduction in all the important histological parameters that I went over earlier in the TMJ of conditional knockout mice, which indicates that there was a hypoplasia in the TMJ. And to understand the mechanism a little better, we switched gear to an in vitro model using mouse bone marrow stem cells from the global knockout mice and human dental mesenchymal stem cells from the dental pulp. Human stem cells were treated with siRNA to knock down P75 in vitro. Cells were cultured in the chondrogenic media for 7 days to promote chondrogenic differentiation. Then we performed LCM blue staining and qPCR to assess the level of differentiation. This is the result of LCM blue staining for both mice and human stem cells. In both, we found a significant suppression of chondrogenic differentiation in P75 deficient cells compared to controls. Here, qPCR analysis of the knockout mice shows that key chondrogenic markers were again reduced in expression in the knockout mice. So in conclusion, my project had 3 key takeaways. First, we were able to successfully generate the knockout mice in which P75 was specifically deleted. Second, the resulting hypoplasia of the TMJ condyle indicates that P75 is important for maintaining homeostasis and architecture within the TMJ cartilage itself. Lastly, in vitro analysis with stem cells showed that P75 is a key regulator of chondrocyte differentiation in both mice and human cells, and it also acts, at least in part, in a cell-autonomous manner, meaning it doesn't require external signals from neighboring cells. So as a next step, we plan to investigate the downstream signaling pathways involved in this mechanism, and in the future, identify potential therapeutic targets and delivery strategies. Last but not least, I want to give a special thank you to my amazing mentors for their mentorship and support throughout my project. And of course, thank you to all my lab members who've helped me throughout the year. I also want to thank Dr. Behrens and Roger for their support and the D2 Fellowship Program for funding this project. This is the reference slide. Thank you for listening. Yeah, any questions?
Very interesting presentation. Just a question, like which mouse model you are using for your first year?
Reproducible? Yes. So we had different sample sizes for different experiment, but for my main experiment with the histological analysis, I believe for the conditional knockout mice, we had about 8 samples, and then the control mice, we had 6 mice, and then we purchased the mice from Jack's lab, laboratory. Family, I might have to take a look at that.
Hi Jay, great presentation. I was wondering why you decided to choose postnatal day 7 to start injections.
So for postnatal day 7, we did some literature reviews beforehand, looking at similar experiments that use aggregate, and we also did some internal experiments within our lab to see how the TMJ defects, when the TMJ defects become apparent. We looked at embryology, like stage, and then P7, P0, P14, and so on. And we found that at P7, the TMJ defects becomes apparent and becomes statistically significant. So that's why we decided to target at P7.
Hello. Hi. You might have went over this, but maybe I didn't catch it. Have you found that in the literature, like patients that present with TMJ issues have down-regulated P75 NTR mutations, or?
That's a really good question. So our lab is currently working on more experiments, and one of them includes looking at the actual TMJ samples from human. And we did found downregulated P75 in those disease samples compared to healthy samples.
Thank you so much for the great presentation. The next presenter is Andres Betancourt Torres, mentor Dr. Allison, and the title of presentation is Chromosomal Sex and Gonadal Sex Independency and Interactivity Influence Bone Structural and Mechanical Properties, Osteocyte Gene Expression, and Osteoarthritis Progression.
Thank you so much. All right, I'll go right into it. My project looks into understanding better how osteoarthritis is influenced by sex. We know that OA shows a higher prevalence in women when compared to men. And in a meta-study by Sean and colleagues, they looked at more than 250,000 patients in more than 200 countries, and estimated that most of the osteoarthritis patients were women, and it's one of the highest predictors of osteoarthritis occurrence. Also, osteoarthritis involves various joint symptoms, including cartilage loss, thickening of the subchondral bone, as well as different pain perceptions and sensitivities. So in order to explain this gender difference between men and women in humans, we look at the influence of sex. Usually when we think about sex, we think about the effects of sex steroids being released by testes or ovaries, which result in a systemic masculinization or feminization of the mammalian organism, including mice and humans. However, there is also differential gene expression that comes from the XY and XX chromosomal combinations, which acts in a more cell intrinsic manner. And all of this combines results in sexually dimorphic phenotypes, including disease phenotypes. Therefore, understanding chromosomal and gonadal sex contributions can define sexually dimorphic mechanisms in the skeleton, osteoarthritis, and other conditions. So the research question that I'm going to explore in this presentation is if chromosomal and gonadal sex are contributing differently to osteoarthritis. And our hypothesis is that chromosomal sex and gonadal sex contribute differently to osteoarthritis pain sensitivity, joint degeneration, and subchondral bone thickness. So in order to take a step forward in looking into sex differences, we used the 4-core genotype mouse model. In this mouse model, the SRY gene, the sex differentiation gene in the Y chromosome, is silenced, but it was reinserted in an autosome. Therefore, the sex determination is independent from the sex chromosomes. This allows us to have 4 groups of mice, the typical XX ovaries and XY testes, but also let us have XX testes and XY ovaries. So by using this model, we can go from the typical separation of male and female of all the chromosomal and gonadal sex effects combined to attribute independent effects from the sex chromosomes or from the gonadal secretions. So I'm going to start by showing you some data related to pain tests. This is in collaboration with Dr. Kelsey Collins' lab. We took a cohort of these mice and induced osteoarthritis on the left knee using the destabilization of medial meniscus surgery. And we tested for pain. And the graphs that you will see, the lower the value in the scale, the more pain sensitivity it shows. So at 4 weeks post-surgery, we look at pressure pain thresholds. These are abnormal response to mechanical stimulation. That's the pain that we're looking at. And what we determine is that there is a main effect from gonadal effects, specifically from ovaries, which are lowering this threshold. 12 weeks, we look at static weight bearing. This is a measure of spontaneous pain. And what we observe are independent effects, main effects, from chromosomal sex and gonadal sex, with contributions from the XY chromosomes and from the testes to this type of pain. We then, at 12 weeks, sacrificed these mice and did histological studies. This is specifically with safraning O, what you see in the images. Red corresponds for cartilage, and blue mostly corresponds for bone. And the loss of cartilage and the complication of the joint damage is captured in the Mankin score. And what you can see is that we identified main effects from gonadal and chromosomal sex, specifically an increase due to XY chromosomes and also by testes. And we also look into, through micro-CT, we quantify the subchondral bone plate. And as you can see, we have the typical, we have a typical sexual dimorphism observation from the typical genotypes. But when combined with the, all four groups of the four core genotype, we identified main effects from gonadal sex and chromosomal sex. Specifically, the XX chromosomal combination and the ovaries increase the thickness of the subchondral bone plate, which is a complication of osteoarthritis. So overall, we observe that ovaries independently contribute to the sensitivity to the mechanical test in pain. The XY chromosomes and testes contribute to the spontaneous pain. We also have observed that testes and XY chromosomes contribute to the joint degeneration, particularly cartilage loss that is captured through the Mankin score. And ovaries and XX chromosomes contribute to the thickening of the subchondral bone plate. So this overall shows that sex affects osteoarthritis through gonadal sex and also chromosomal sex. And this observation suggests that chromosomal sex and gonadal sex can affect health outcomes in an independent manner. We're observing this for osteoarthritis, and this opened the question to arthritis, for example, in TMJ, or dental conditions as well that show sexual dimorphism. With that, I would like to thank our amazing collaborators in the Collins Lab, particularly Kelsey Collins, who has been a great mentor on guiding me through the osteoarthritis research, and also my home team in the Alliston Lab. And with that, I'll be happy to take any questions.
I have a question.
Yes.
Very interesting work.
Thank you.
Was there any differences when you look at like a younger cohort of mice or like age mice, or like do you think that would be a factor in that?
So yes, what's the question?
Like effect of like aging.
Effects of aging in mice. Yeah. So the mice we looked at are at 5 months old. The reason for that is because there's published data at that time. That's usually when that surgery, the DMM, is done. And it's not a very young mouse because arthritis is associated with aging. So it's a middle-aged mouse, what we look at approximately. But the question is still open, how aging contributes to it, specifically because there can be contributions from XX chromosomes. There can be X chromosome reactivation with age, so that it's possible to overlap with arthritis.
Thank you very much, Andres, for a great presentation. The next presenter is Daniel Pirous. Mentor is myself, and the title of presentation is SB140 regulates macrophage transcriptomics and oral mucosal homeostasis.
Okay, well, hello everyone. My name is Daniel Pruz. I'm a D1 here at the School of Dentistry. This is my project that I participated in the pre-D1 Research Fellowship as a member of Dr. Momin Haravi's lab. So what exactly is SP140? Well, it stands for speckled protein 140 and accordingly is a member of the speckled protein family, which is a group of epigenetic readers that can be restricted to the nuclear periphery of immune cells like macrophages. It's composed of numerous domains that can be seen here on the lower right, and each of these domains have some known functions but still remain largely uncharacterized. And because of its immune restriction, SP140 has also been previously studied for its role in immune diseases such as Crohn's disease and multiple sclerosis. With this knowledge, our lab has previously studied SP140's role in tumor-associated macrophages, otherwise known as TAMs, in various cancers such as head and neck squamous cell carcinoma. This research found that SP140 expression was positively correlated with increased immunotherapy responses and increased anti-tumor M1 TAM activity in head and neck squamous cell carcinoma tumors. But what could explain this? Well, SP140 has also been shown to affect many cellular processes in previous research, ranging from preventing DNA damage to increasing MHC2 antigen presentation by macrophages in order to boost T-cell mediated immunity. So my project sought to understand some of these mechanisms in order to study and investigate SP140 as a potential therapeutic target for oral diseases. So let's go into a brief overview of the methods behind this project. One of our first aims was to study SP140's role in periodontal diseases and oral diseases. To do this, we performed immunofluorescence staining of de-identified healthy and diseased human periodontal tissue samples. These samples were all previously collected and embedded in paraffin, so we began by deparaffinizing the tissue and conducting antigen retrieval to unmask our target proteins. We then proceeded with routine imaging and staining protocols, and then we compared the levels of SP140 positive macrophages in the healthy versus periodontitis samples. Our next aim was to study SP140's role and the mechanism behind its MHC2 antigen presenting enhancement. We did this by stably knocking down SP140 in THP1 monocytes using shRNA. Then we transduced these monocytes with lentiviruses overexpressing SP140 domain mutants. So we basically knocked down the SP140 and put it back in with one of the domains mutated. We differentiated these into macrophages using PMA and then analyzed the lysates using Western blotting and ChIP-qPCR. Finally, our last aim was to study SP140's role in DNA damage prevention in macrophages. To do this, we performed a COMET assay, which involves knocking down SP140 in THP1-derived macrophages, then administering cisplatin, an agent that induces DNA damage. We then induced cell lysis and measured the amount of DNA damage using electrophoresis. Now let's discuss our results, starting with periodontal tissue staining. Here is a 10x image comparison of healthy and diseased human periodontal tissue samples. Qualitatively, you can probably see that the bottom diseased images show a greater number of SP140 in red and CD11B in green signals relative to the healthy. But now we can take an even closer look. These are magnified 20x image comparisons of the same samples, and it should hopefully be easier to see now that the levels of CD11B and SP140 expression are vastly greater in the disease compared to the healthy sample. But now let's move more into some quantitative analysis. We analyzed the number of signals expressing DAPI, CD11B, and SP140 in the connective tissue of our samples to ensure we are only quantifying SP140 positive macrophages. The images to the left are examples of our analysis conducted in Fiji, and the scatter plot to the right displays our results. You can see that there is a statistically significant difference in the number of SP140 positive macrophages in the diseased periodontitis sample compared to the healthy sample, indicating that SP140 likely has some role in oral mucosal homeostasis. Now let's go over our results for MHC2 antigen presentation. This slide shows our results of the Western blot following the knockdown of SP140 and rescue using our lentiviruses. Our previous findings informed our decision to target H3K4ME3, which is a histone modification that we believe increases the expression of MHC2 antigen-presenting genes. The wild-type positive control here showed the presence of H3K4ME3, while our negative control did not. When we rescued these knockdown cells using the lentiviruses, H3K4ME3 levels were rescued in all domain mutants except for the SAN domain mutant. So essentially, this shows that H3K4ME3 is present in the lysate of all of our samples except those without a proper SAN domain, leading us to infer that it's responsible for H3K4ME3 attachment to the chromatin. To confirm these results, we performed CHIP qPCR. And for this, we analyzed H3K4-ME3 attachment at the NFAT5 locus, which is a gene responsible for MHC2 antigen presentation in macrophages. We see that in our wild-type SP140 and negative control SP140 knockdown samples, there is higher and lower enrichment of NFAT5 respectively. So this informs us that H3K4-ME3 attachment at the NFAT5 locus is SP140 mediated. When we rescued the knockdown cells with our full-length SP140 protein, the wild-type enrichment was restored. But when we rescued using a SAN domain mutant, enrichment stayed low, indicating that the SAN domain is required for H3K4-ME3 occupancy at NFAT5. Finally, let's discuss the results of our COMET assay. Our lab found that the cells treated with cisplatin and SP140 siRNA exhibited the greatest degree of cisplatin-induced DNA damage. The smears on the DNA tail are representative of damaged DNA fragments that were dragged out of the nucleus during the electrophoresis process, with the head representing the nucleus of the cell, that little circle. To quantify our findings, we calculated something called the olive tail moment of each sample and charted it on this scatter plot. The olive tail moment is essentially a measurement of the percentage of DNA found in the tail of the sample relative to the head. And it is essentially meaning that a higher olive tail moment is more indicative of greater DNA damage. So our results here are indicative that the SP140 knockdown and cisplatin treatment experienced the greatest extent of DNA damage, and that SP140 plays a role in preventing it. So to close out, our results helped us determine that SP140 plays some role in the homeostasis of the oral mucosal region. We found that the SAN domain of SP140 is responsible for regulating macrophage transcriptomics by influencing histone modifications that enhance MHC2 antigen presentation by macrophages to CD4+ helper T cells. We also found that SP140 plays a role in safeguarding DNA from damage, likely to support macrophage proliferation and stability. And we're planning on building on this finding using ongoing DNA fiber assays to assess SP140's role in preventing DNA damage during the S phase of replication specifically. With all of this, our findings lead us to believe that SP140 is an important regulator of innate immunity and macrophage function, and that it represents a potential therapeutic target for oral diseases. I'd like to give a special thank you to the Milgram Endowed Scholarship Fund, the UCSF Dental Student Research Fellowship Program, Dr. Momin Haravi, Dr. Ali, and the rest of the members of the Momin Haravi Lab. Without them, this project would not have been possible. Thank you. Any questions? Yes.
So what might be some of the clinical applications of your project?
Great question. So there are different oral diseases to consider when we're looking at the clinical application. For a cancer such as head and neck squamous cell carcinoma, it would be more favorable to increase the expression of SP140 such that it has a more anti-tumor effect in the macrophages. So that can involve anything like a transgene delivery like AAVs, mRNA therapeutics, or even CRISPR. But for something like periodontitis, where inflammation is a big problem, it might be better to decrease the SP140 expression using something like CRISPR as well.
Hello, I just want to say you did an amazing presentation.
Thank you.
Also, I want to ask, how did you quantify whether the cells like a high versus low expression of SP140 protein?
Yeah, so we use Fiji, which is another like a flanker of ImageJ, and essentially you're able to relatively compare like the signal intensity of one signal compared to the others. So just using that program, we were able to, it was able to, using a computer mechanism to identify that SP140 is more greatly expressed in these areas compared to these. And then using that, we were able to quantify. Oh, yes.
Have you validated these results using human macrophages, or have you only worked with THP1 cells?
Well, I believe THP1 is human-derived, so. Yeah, nothing has been done in vivo or from any directly replicated human macrophages, just these THP1s, but something to definitely consider for our future experiments.
Thank you, Daniel. Our next presenter is Marisa Campaign, mentor Dr. Velu Pillai, and the title of presentation is An Old Antibiotics, a New Approach, Topical Doxycycline for Oral Neutropenic Ulcers.
Hi there. As we already heard, I'm Marissa, and I'm an oral medicine resident. I will be presenting today about topical doxycycline for oral neutropenic ulcers. Our patient is a middle-aged male with a history of lymphoma who presents with a 3-month history of an ulcer causing severe pain and swelling on his right tongue. This started looking like it did in the box on the left 3 months prior to our initial visit. And by the time of the consult, the patient was in so much pain that he could barely eat or speak and couldn't sleep longer than an hour and a half during the night. Oxycodone didn't control the pain, but it did cause vomiting, which worsened the oral inflammation and worsened his ability to get any food. He had been treated with various medications, but none had resolved the symptoms. His medical history was significant for follicular lymphoma, which was treated with chemo. After the chemo, he then developed severe neutropenia. Neutrophils are an essential part of our immune system and are the first responders to microbes that in our bloodstream or in wounds. And a common treatment, and neutropenia can be extremely dangerous for our patients. A common treatment for neutropenia is a medication that increases the number of neutrophils in the bloodstream. Unfortunately for our patient, the increase in neutrophils caused him to develop what's called sweet syndrome, which is a severe rash with fever and is a dermatological emergency and is caused by neutrophils attacking the skin. The importance of this was that it contraindicated the further use of this type of medication, which left this patient with no way to return his normal numbers of neutrophils, left him with prolonged severe neutropenia. To get a bit of context, this is a graph of the patient's neutrophil count over about a year. The orange line is the low end of normal, and below the red line is severe neutropenia, where infections can quickly become life-threatening. For context, neutropenia lasting longer than 7 days is considered high risk, and this patient's neutropenia lasted for about 10 months. For a quick overview of his medications, a 10,000-foot view, he was on various agents for antimicrobial prophylaxis because to try to help him fight infections. He was also on systemic and topical anti-inflammatories for his sweet syndrome. He was taking oxycodone. At the time of our visit, he was taking oxycodone and had a history of treatment with Dilaudid for the pain from the ulcer on his right tongue. If any of us aren't familiar with Dilaudid, Dilaudid's actually 8 times stronger than pure morphine, and that was the degree of pain that this patient was experiencing from his tongue lesion. He was also on anti-nausea and anti-constipation medications for the side effects of the opioids, as well as several medications trying to address his oral ulcer. When we see ulcers in the oral cavity, the differential diagnosis is huge. We don't need to go over all the possible causes of oral ulcers, but the importance of having this differential was for us to know what needed to be ruled out. And luckily, the patient had had a lot of workup prior to our first consult, which had already ruled out various causes. Clinical tests, including a biopsy, showed us the ulcer wasn't viral, it wasn't a deep fungal infection, cancer, or an autoimmune disease. This helped us conclude it was most likely what's called a neutropenic ulcer. I'll talk more later about exactly what that means, but at the first consult, all we really had to do was irrigate the large soft tissue defect here on the right tongue with chlorhexidine, which fortunately and somewhat surprisingly resolved the patient's symptoms for a while. Unfortunately, about 2 months after this initial consult, the patient presented with new ulcers at various sites in the mouth. As we can see, these new ulcers are large, various areas in the mouth. They have a bright red ring around them, meaning the tissue is very inflamed. They also have a thick, the thick yellow material on top is called a pseudomembrane, and this is a combination of bacteria and necrotic tissue. At this point, the patient again was having difficulty speaking, difficulty eating, and difficulty even sleeping through the night due to severe pain. Oxycodone, viscous lidocaine, and ibuprofen helped to some extent, but weren't really resolving the issue. And we can see that his neutrophil count at this point was 0.05. This is approaching what's called agranulocytosis, which is pretty much neutrophils are non-detectable in your bloodstream, and this is a bit of a medical emergency at this time. He has severe neutropenia. At this point in time, we decided to initiate treatment with a doxycycline topical rinse. The rest of his team was trying to figure out what to do with his systemic health, but the best that we could do at this time is try to help with the oral ulcers. We had him start opening one 100 milligram capsule of doxycycline into 15 milliliters of water and holding it in his mouth as long as he could tolerate, up to 5 minutes, 3 times a day. We chose doxycycline because doxycycline, in addition to being a broad-spectrum antibiotic, it also has anti-inflammatory properties. It inhibits matrix metalloproteases and can decrease inflammatory cytokines, which can help with long-term chronic inflammation. It's historically been used for aphthous ulcers, and minocycline and doxycycline are used in periodontitis in a topical fashion. So over the next month, it seemed to work. Unfortunately, in the middle of this treatment period, about a week after this photo, the patient had to be hospitalized for severe esophageal ulcers, which were believed to have a similar nature, being kind of neutropenic ulcers at a different site in the digestive tract. At this time, however, his oral ulcers were stable. He still had pain, but the pain was controlled. The pain wasn't getting worse. And in this picture, we can see from his admission, this was taken during his admission, we can see a much thinner pseudomembrane covering the ulcers. By about a week and a half or 2 after he was discharged, we can see that there was significant healing of these ulcer sites. These are just a couple more pictures of what he looked at about 2 weeks after his discharge. And at this point, the ulcers had almost healed. He had no oral pain at this time. He did have some esophageal pain, but the lack of oral pain meant that he could eat his diet that he needed to eat for his esophageal pain without having to worry about additional limitations on his consumption due to pain in his mouth. We can see that new epithelium covers the former ulcer sites, and this is tissue that is healing. As a reminder, here's that same chart of his absolute neutrophil count. We can appreciate that, the dark green arrows mark appointments after starting the topical doxycycline, and we can appreciate that the second set of ulcers was able to heal without resolution of his neutropenia. And again, this red zone is what's called profound neutropenia, and grade 4 neutropenia, extremely severe. So what is a neutropenic ulcer? A key takeaway from this talk is that the neutropenia itself doesn't damage the epithelium in the mouth. We commonly understand that neutrophils keep bacteria from colonizing wounds, but recent research has shown that they also remove cellular debris and play a key role in activating other cells that allow tissue repair to take place. This is a complex diagram, but we can see that neutrophils secrete cytokines, which help to differentiate macrophages and help to signal the rest of the tissue to actually physically start healing the wound, in addition to their role in fighting bacteria or other microbes. So in terms of what caused the wound in the first place, the answer is likely as simple as small wounds from everyday function. You can think about how often you get little wounds in your mouth from eating a sharp piece of food or accidentally biting your cheek. In patients like our patient, without neutrophils, these cuts get colonized by the normal oral flora in the mouth and can't heal because they're missing a key part of the team, which coordinates the inflammatory and healing response. This is why topical doxycycline might be effective in such cases, because in addition to killing the bacteria, it has the potential to reduce the harmful chronic inflammatory processes that are taking place due to the lack of neutrophils. In cases like our patient, doxycycline may let us control oral ulcers without having to rely on normalization of the neutrophil counts. This can reduce the risk of systemic infection and also significantly improve quality of life for patients with prolonged neutropenia. Right now, if you have neutropenic, many patients during stem cell transplants or with hematological malignancies like our patient just have to deal with severe oral ulcers until they get their neutrophils back. But this could be a good, relatively inexpensive and easy to access option for controlling these oral ulcers until they can get their neutrophil counts back up. I would like to thank my sources as well as all of my faculty mentors at the Oral Medicine Clinic, and especially Dr. Piri Villupoli for helping me with it and mentoring me on this project. I would also like to thank all of you for your time and attention.
Can I ask a question? This is great. Sorry I caught it in the middle, but he has this neutropenic, and I don't know how long they had because I missed the first portion, but
10 months.
10 months. Did you check periodontal disease in bone loss? It's very common to have, aggressive bone loss in the patient.
That's a really interesting question. I didn't have time to include it, but this patient, we had to be very, very careful with the amount of manipulation we were doing in his mouth. To do the biopsy, he tried to undergo irrigation and debridement, and after the biopsy, he had to be hospitalized with a neutropenic fever. He also had bad RSV, but any sort of invasive treatment resulted in his immediate fever and hospitalization. So we did not actually get probing depths, and you can see a little bit of calculus and erythema of the gingiva. In an ideal world, it would have been really helpful to evaluate his periodontal status. Unfortunately, when he had a neutrophil count of 0.05, we were trying to avoid any invasive treatment whatsoever. But I think that's a great question. And now his counts have improved, and possibly that could be something that we could look at with him now.
Yeah, obviously that was the origin. Did you try by any chance chlorhexidine mouthwash before the doxycycline?
He had been on it, and we did continue it, yes. So doxycycline really could form part of the team, part of the kind of mix of things that can help these patients try to do something about their ulcers. So yeah, it could help as well.
So thanks for a great presentation. It was a really interesting case. My question is, when the patient was hospitalized and had the esophageal lesions, was there any systemic treatment for that? What kind of treatment did the patient get for that? And might that have helped with the healing of the oral lesions as well?
Yes, they actually went in and did a biopsy of the esophageal lesions. They initiated some antivirals just before they did the biopsy to see if it could be CMV or some other viral ulcer. Did a biopsy, ended up that it was not anything besides probably he'd been taking ibuprofen, so possibly that had caused chemical damage that initiated the ulcer, but they gave him pain control, sucralfate, and eventually they did start him on a different chemo for his lymphoma that did improve his neutrophil count eventually, but it was honestly pretty palliative during his hospitalization.
But no systemic doxycycline, for example.
He also had another leg infection, or it was the Sweet syndrome, so he was taking some systemic doxycycline, kind of scattered throughout the treatment period, but they didn't start it during his hospitalization.
Okay, thanks.
Thank you.
Hi, I have a question. Thank you for the presentation. Here. Sorry. I have a question. So did you do any culture sensitivity tests regarding the ulcer? What led you to conclude the doxycycline as the treatment for the ulcer? Was it the first line therapy for the ulcer, or did you try any other antibiotic for that ulcer?
He had been on amoxicillin in the past that hadn't done anything. Various cultures were done and didn't actually show. They didn't come back positive for gram-negative bacteria or anything like that. The bacterial cultures were nothing remarkable. So the reason we chose the doxycycline was because it is pretty broad spectrum, but also because of the anti-inflammatory mechanism that was there. So it wasn't just the antibiotic that we needed. We also needed something to help with the chronic inflammation. So that's why we chose. And we did have various viral swabs and bacterial swabs, and nothing came back with something that was treatable, say, with an antiviral or an antibiotic.
I mean, since he was already on so many immune modulators and steroids, wasn't it helping him to control the inflammations?
By that point, he was no longer on prednisone. By the second ulcers, he was no longer on prednisone, and his dapsone dose had been significantly reduced. So he wasn't on those immunosuppressants, actually, at the time of the visit. The original med list was at the first consult. So he was on systemic antibiotics. He just wasn't on any prednisone or anti-inflammatories.
Thank you.
Thank you.
Thank you, Marisa. The next presenter is Isabel Lao-Ngo. Mentor is Dr. Govind, and the title of presentation is that what is the incidence of complications in nasotracheal intubation for dentistry and oral and maxillofacial surgery?
Thank you.
Hello, everyone. Thank you so much for being here. My name is Isabel, but I also go by Belle Lao Ngo, and I'm very excited and honored to present a bit about my research with my mentor, Dr. Akshay Govin. And my project is titled, What is the Incidence of Complications in Nasotracheal Intubations for Dentistry and Oral and Maxillofacial Surgery? And so, to help you understand our story a bit, let me set the scene. Imagine you're in the operating room preparing for maxillofacial surgery. The plan is for nasotracheal intubation. As the anesthesiologist advances the tube through the nasal passage, sudden bleeding begins. The oropharynx quickly fills with blood, obscuring the airway. Oxygen saturation drops. The patient's life is in immediate danger. Now, cases like these led us to our research question because we asked ourselves, how common are these complications? And so you're probably wondering, what is nasotracheal intubation? It's essentially an airway management technique where the breathing tube is passed through the patient's nose and down into the trachea to maintain an open airway for breathing. And so why is this important? Unlike oral tracheal intubation, nasotracheal intubation keeps the mouth clear, providing the oral surgeon with unobstructed access to the surgical site. Sorry. Oh, okay. However, the current risk profile for its use and incidence of complications in nasotracheal intubations for dentistry and oral surgery is primarily in pediatric literature and not in adult literature. And so that led us to the specific aims of our project, which were to retrospectively analyze and describe the experience with nasal intubation at a single health system over approximately 5 years, describing the incidence of complications and exploring for predictors. Our question is simply, what is the incidence of anesthesia complications in this cohort, while also exploring for the predictors? And so, how did we do this? Let me walk you through. First, we had a retrospective cohort study conducted within Alameda Health System up in Oakland, and we reviewed operating room logs within Epic for dentistry and oral surgery from 2019 to 2024. This led us to 1,594 anesthesia records to review, and we included patients that underwent intended nasotracheal intubation under general anesthesia for dentistry, excluding those that were treated outside of the operating room and those that didn't use intended nasotracheal intubation for dentistry. And finally, this yielded 480 cases in our sample for analysis. And just to show you some variables that we analyzed, our predictors included the following: indications, Mallampati score, intubation time, number of attempts, nasal prep, nair insertion site, and laryngoscopy type. Our main outcome was anesthesia complication, and we also adjusted for covariates of age, BMI, sex, and the American Society of Anesthesiologists physical status, also known as ASA status. So what did we find? For our cohort's demographics, we found that with our 480 sample size, the mean age was 38.13 years, 66.67% male, and a mean BMI of 26.52. And the most frequent indication for using this type of intubation was for dental rehabilitation or extraction, followed by facial trauma, pathology, head and neck infection, orthognate surgery, and then reconstruction. We found the mean intubation time was around 4 minutes. It ranged from less than a minute to the longest being 28 minutes. And for complications, to answer our question, we found that the incidence of complications was around 5.42%. The most common was epistaxis at 62.5%, and following that was excessive difficulty with intubation, pharyngeal complications, pulmonary complications, and other. Most cases show no adverse effects. And finally, we found that the most significant predictor of complications was number of attempts and also higher ASA status. And this kind of makes intuitive sense as the more times you attempt the nasotracheal intubation, there would most likely be more complications. And so as this graph shows, number of attempts increases and then complication and epistaxis rate also increase. And Finally, to conclude, because our study was a retrospective study, we did have some limitations. Our data was entered by multiple providers without calibration. All procedures were performed at a single institution, and our study only captured complications during immediate perioperative period. And so finally, just to tie this all in and answer our research question, which was what is the incidence of complications in nasotracheal intubations for dentistry and oral maxillofacial surgery? The answer is 5.42%, with the most common complication being epistaxis, also known as bleeding. I should have mentioned that earlier. And then finally, our main predictor was number of attempts. And then here are a few of our references. And of course, I need to thank some very important people. My mentor, Dr. Akshay Govin, as well as my colleague, Nicholas Saber, and Zhenzhen Zhang, Sophie Fang, and Avidas Boyadzan. And with that, that brings me to the end of my presentation. Thank you all so much for listening, and I hope you enjoy the rest of RSED. Forgot about questions.
Hi, Belle. I loved your presentation. I'm up here. How did you define complication? Like, what is your definition of complication?
Hi, Dr. Starr. Thank you so much for that question. So complications, we mostly looked at like immediate complications. So we looked at things that were indicated in the chart notes on EPIC that the anesthesiologist noted during that period of intubation. So anything that was kind of like, I think some blogs had mentioned like asthma as a complication, but that's not really something that happened because of the intubation. So anything that the anesthesiologist or surgeons recorded that was like happening during that period of intubation.
So your definition of complication is something that happened during the intubation that was unexpected?
Yes, exactly, yeah.
Okay.
So like something like bleeding or pulmonary complication. They had specifically mentioned that it happened during that procedure. Yeah.
And do you think that placing a tube through someone's nose and having the nose bleed is an unexpected complication?
No, definitely not unexpected, which was why I definitely saw that since it was the most frequent, it wasn't unexpected, but yeah.
Okay, thank you.
Thank you for the question.
My question is, why is this work research important? What should we do with this information, and why do we need to know about like the incidence of these?
Yes. Oh, wait, where are you? Oh, okay, sorry. Why is this work important? Yeah, so most of the literature is mainly in pediatric literature, and so there isn't that much research about intubation amongst adults, and also like finding the incidence of complications isn't really a highly studied topic. So because nasotracheal intubation is such a risk adverse thing to do in surgery, like patients could eventually maybe die from complications, I think it's very important to study the incidence or things that could reduce the complications for adult patients in oral surgery, since it is an underrepresented topic. Thank you. Mm-hmm. Yeah, great question. So it was manually done. It was me and then our mentor and then two other people that we worked with. We all manually checked the records. We used Slicer Dicer to generate the initial 1,594 list, and then from that we manually just went through the inclusion and exclusion criteria to generate the 480 sample list. Yes. Yes, yeah. Yeah, we mainly used our mentor to help give the final decision if there was like any discrepancy. Yeah. Thank you so much.
Thank you very much, Isabel. The next presenter is Jake Ngo, and mentors are Dr. Zhang and Dr. Dembeston, and the title of presentation is Defective Enamel Maturation in a CFTR Conditional Knockout Mouse Model.
Hi, thank you. Thanks for the wonderful introduction. My name is Jake. I'm a third-year PhD candidate in the OCS graduate program, and I am mentored by Drs. Pam Dembeston and Dr. Yan Zhang. And one of the primary focuses of our lab is to really understand the basic mechanisms underlying tooth enamel formation, as well as how certain environmental factors and how genetic conditions perturb this process. And one of the genetic conditions I wanted to focus on today is cystic fibrosis. And I think a lot of you may think immediately and associate, well, cystic fibrosis is that really clear and really stark lung phenotype where there is a clear mucus accumulation, mucus thickening that makes it really hard for patients to breathe. But what I wanted to emphasize is that cystic fibrosis is actually a very multi-system disorder. It affects a whole host of tissues, including dental enamel. And this is in part because cystic fibrosis is caused by a gene called CFTR, which is expressed in a whole host of different tissues. So this sort of drives the sequential question of this project, which is, well, are the enamel malformations that we observe in patients with cystic fibrosis due to primary ameloblast intrinsic defects? As obviously, organ systems are highly interconnected, and they can have different secondary or indirect effects on the tooth enamel formation. Another thing is that a lot of the early reports of associating cystic fibrosis with enamel defects have tied this to antibiotic use, specifically tetracycline, which is known to cause enamel defects. So this project really aims to sort of parse this out and understand what is exactly the role of CFTR in enamel formation. Really briefly, what I want to go over is the different formative stages of amelogenesis, where it's broken into two functional stages. The secretory stage, which really is meant to set the thickness of the enamel, and the maturation stage, which is really there to resolve those enamel matrix proteins by cleavage, enzymatic cleavage, reuptake, and to replace it with mineral through extensive ion transporting capacity. So you might be wondering, well, we're looking at direct effects of cystic fibrosis on enamel formation. You might wonder, well, is CFTR expressed in the ameloblast? And the answer is yes, and it's actually expressed in a highly stage-specific manner. Specifically found in the maturation stage of the ameloblast formation, as seen in this immunohistochemistry staining on the left, and also by quantitative PCR, where we looked at different developmental time points that we know are associated with the maturation stage, and compared that relative to P5, which is the earlier developmental stage or the secretory stage. So this stage specificity I bring up because it's really important for our strategy to conditionally delete CFTR from maturation stage ameloblasts. In that, because it's so specific, we opted to use the ODAM pre-mouse model, which ODAM is a biomarker not only of ameloblast, but also of the maturation stage. So we drove Cree expression using the ODAM promoter and crossed that with the CFTR flox mouse. And what we ended up finding, interestingly, is that when we conditionally deleted CFTR from the maturation stage of ameloblast in mice, we found a very stark enamel phenotype in the conditional knockout mice. Namely, this really clear color defect as well as a hypomineralization, as seen by the micro-CT scans on the right, and also a fracturing of the enamel from the DEJ. When we go ahead and look at the cellular level, what we noticed by the H&E staining of different stages in enamel formation, what we found is that obviously given our conditional deletion model, there is no obvious change in the earlier secretory and the transition stages. But when we look over in the early in maturation and mid-maturation stage specifically, we see a very clear disruption to the cellular morphology and especially cell height as we start to see in the mid-maturation stages. But the thing that we sort of found most starkly changed was something to do with something called ameloblast modulation. Ameloblast modulation is this really interesting cellular phenomenon that we observe in maturation stage where the cells will cyclically modulate between what are referred to as ruffle-ended and smooth-ended cells. And these ruffle-ended cells have these really actin-rich membrane protrusions at the apical pole that are not found in these smooth-ended cells. And conversely, these ruffle-ended smooth-ended cells are associated with very distinct protein localization patterns that cyclically modulate along with the cell morphology. As you can see in panel C and D on the right, these markers of these ion transporters cyclically modulate between ruffle-ended and smooth-ended. And conversely, when we look at the actual incisor, the enamel itself, these enamel will cyclically modulate between bands of a slightly acidic matrix and cyclically modulate to neutral and do this over and over and over again throughout maturation until it completes. So when we look at our conditional knockout model, what we ended up finding was, indeed, CFTR leads to this defective enamel modulation. So on the top is the control mice and the knockout on the bottom, and we can see that this cyclic modulation between a slightly acidic matrix and a slightly neutral matrix is largely lost in the conditional knockout, where it remains largely acidic. And when we go further than this, what we ended up looking is, okay, when we go to the histology and look at something like beta-actin, which is the marker of those ruffle-ended and those smooth-ended cells, we can see that at the very apical edges of the maturation stage in the control mice, they will cyclically modulate between ruffle-ended cells in the third panel A1, become smooth-ended cells which actually lose these actin protrusions, and they recyclically back up. But in the conditional knockout, they form in this initial ruffled border that is largely lost and does not recapitulate and come back afterwards in different stages. When we go ahead and look at an ion transporter, in this case, the ATP6B1A, which is a catalytic subunit of the vacuolar ATPase, which secretes protons into the enamel matrix. What we found is that this cyclic modulation pattern also is repeated as well, where the ameloblasts are able to cyclically modulate in the controls, whereas the knockouts form one initial ruffled border, but again also fail to relocalize and stain at the apical edge of these cells. Finally, when we looked at one of the final components of enamel maturation, which is the removal, reuptake, and processing of the enamel matrix, when we go ahead and look at the H&E section of these sagittal sections, we can see there's a very clear retention of enamel matrix proteins in the conditional knockout mouse, which is further corroborated by staining for the major ameloblast and enamel matrix protein amelogenin. It is largely retained, as you see in this bottom panel on the right, labeled D, this brown staining that is retained in the enamel matrix. When we go ahead and further microdissect out those incisors and we process them for protein analyses by SDSPH, we find that there is also this, you can also see that this retention of amelogenin and amelogenin-like substances in the SDS page, and also retention of amelogenin in the immunostaining on the right, and also in find of intracellular amelogenin, which is a marker of reuptake of this protein, which is largely lost in the conditional knockout mice. Finally, when we looked at one of the actual enzymatic processing of the matrix, we looked at KLK4 activity through a fluorogenic quench assay. And what we found was that the conditional knockout mice are always showing a significant reduction in KLK4 activity across time points. And this was corroborated by the fact that KLK4 appeared to be significantly downregulated at the RNA level when we performed quantitative PCR. So in summary, what we found was CFTR, when we conditionally delete it from ameloblast, exhibits sort of a cell autonomous observation where the cells, when you knock it out, they cause a severe enamel phenotype, and it shows that CFTR is absolutely necessary for enamel formation. These are the acknowledgements. My great mentors, Dr. Jian Zhang and Pam Dembeston, the OCS graduate program, and as well as everybody in the labs, Dr. Dembeston, Dr. Nakano, and Dr. Zhang. Also shout out to Charlie and Tusa, who did this initial setup of the mouse models and did a lot of the initial characterizations. Thank you so much.
Questions? I have a question.
Yes.
Very interesting work. The accumulation of amelogenin in the cells, do you think that that is more like less turnover of like protein, or like less exocytosis or shedding of that? If you can.
Yeah, so I didn't show this in the presentation here, but what we ended up finding is that there seems to be a defect in endocytosis. We found that markers of endocytosis, so the early endosome markers or clathrin-mediated endocytosis, was significantly reduced in these cells, and that would suggest that in the conditional knockout, they're enabled to not only process it by enzymatic cleavage, but they're also enabled to reuptake it into the cells.
Very nice, yeah. Thank you so much. Okay, the last presenter is Kimia Tawassoli. Mentor is Dr. Star, and the title of presentation is Piloting Telehealth for Post-Operative Care in Pediatric Dentistry.
All right, good afternoon, everyone. My name is Kimia Tawassoli. My pronouns are she, her, hers, and I'm a third-year dental student at UCSF. Today, I'll be presenting our project titled Piloting Telehealth Post-Operative Care in Pediatric Dentistry. This study was conducted under the mentorship of Dr. Jean Starr, Clinical Assistant Professor in Pediatric Dentistry. Okay. When I first started working on this project, our goal was to explore whether telehealth could be a feasible way to improve post-operative care for children treated under GA. Soon after, I had the chance to shadow Dr. Starr and one of the pediatric dental residents in the operating room at UCSF Children's Hospital down in Mission Bay. And that experience really reinforced the importance of our study. I saw how extensive these cases can be. Sometimes every tooth needed some type of treatment, and how challenging it can be for both the child and their family. After witnessing that, it became even clearer that we should be doing everything possible to support families after surgery and prevent future decay. And these are some photos from Dr. Starr's actual OR cases, and we can see how invasive a procedure under general anesthesia can be, and how extensive the caries usually are for a child to have to be hospitalized for their dental care. So for some background, severe childhood caries often requires treatment under general anesthesia, but when families miss post-operative visits, the risk of new decay is high. Telehealth has been shown to improve access and outcomes in many areas of medicine, including post-surgical care, but it hasn't yet been explored in pediatric dentistry. So with that being said, our aim was to pilot a post-operative telehealth program using motivational interviewing, which I'll call MI, to assess feasibility of post-operative visits for children treated with general anesthesia for dental caries. So our study design, this was a cohort study conducted at the UCSF Pediatric Dentistry Clinics between January 2024 and June 2025. We evaluated telehealth visits using the RE-AIM implementation science framework, specifically reach and implementation. Children under age 10 who underwent GA for caries treatment were eligible if their family spoke English or Spanish. And within 2 weeks of the GA procedure, parents were contacted by phone, provided verbal consent, and chose either a telehealth visit on Zoom or an in-person follow-up at UCSF. And 10 dental students trained in motivational interviewing conducted these telehealth video visits using a semi-structured script. And then English telehealth visits were also recorded for detailed data extraction and motivational interviewing quality review. And then this is a study diagram of our study flow. So starting with GA treatment, phone contact within 2 weeks of GA, verbal consent, and then whether the families elected for an in-person post-op visit or a telehealth post-op visit. So I touched upon motivational interviewing. So a key component of our telehealth visits was the use of motivational interviewing, or MI, which is an evidence-based approach for facilitating behavior change. We trained 10 dental students over an entire quarter in MI techniques, and they practiced with mock post-operative video visits before seeing real patients. The telehealth visits had 3 main goals. First, to review healing and to address any concerns parents had after their child's general anesthesia. Second, to engage parents in identifying their own readiness for change, rather than telling them what to do. And third, to support parents in generating their own ideas and strategies to prevent future caries and to reduce the need for repeat general anesthesia. And this last goal, And the last goal is particularly important because it relates to one of our secondary outcomes, the self-management goals parents set, which I'll discuss more in the next slide. So our study population, we enrolled a total of 146 children, 63 in the telehealth group and 83 in the in-person group. In terms of the RE-AIM framework's REACH component, this demonstrates that we successfully engaged our target population of young children who had undergone GA for caries treatment, spanning diverse families across different geographic locations. And looking more closely at demographics, the groups were well matched. The average age at general anesthesia was 5.5 years with no significant difference between groups. Regarding timing, both groups scheduled their post-operative visits at similar intervals, averaging about 31 days after GA, again with no significant difference between telehealth and in-person families. One interesting finding was distance. Telehealth families lived somewhat closer to UCSF on average, 49 miles compared to 73 miles for in-person families. While this trended toward significance, it didn't quite reach statistical significance. And looking more closely, our primary outcome was visit completion, whether families showed up or not. For telehealth visits specifically, we also collected secondary outcomes, including chief complaints, self-management goals that parents set, and oral hygiene behaviors. And all this data was recorded in the EPIC EHR system through UCSF, entered into REDCap database, and Stata was ultimately used for our analysis. So our primary results, attendance rates were notably different between the two groups. Families who scheduled in-person visits were much more likely to complete them, 76% of attendance compared to 43% for telehealth. In-person families were almost twice as likely to attend their post-operative visit. And this difference was highly statistically significant at p less than 0.001. And honestly, this was surprising to me. I expected telehealth to have higher completion rates since it's more convenient for families. However, this finding reveals important implementation challenges. Using the RE-AIM framework lens, we successfully designed and offered the telehealth intervention, but the 43% completion rate indicates we haven't yet optimized how we deliver it. And among families who did complete telehealth visits, engagement was very high. 93% of parents set at least one behavior change goal, most often reducing sugary drinks. Half of parents reported brushing with their child, and 88% used fluoride toothpaste. And importantly, 100% agreed to a 3-month follow-up visit, and 84% said they'd prefer telehealth again for future follow-ups. So in conclusion, we found that telehealth visits had lower completion rates than in-person, 43% versus 76%, which shows some implementation challenges. Still, engagement among those who did complete telehealth visits was very strong, showing its potential value. So our key findings, parents were highly receptive to preventative counseling and goal setting, and all families wanted continued follow-up care. Among telehealth completers, 84% preferred that format for future visits. So telehealth may be most effective for motivated families, complementing rather than entirely replacing in-person follow-up. And looking forward for future considerations, we'll work to identify barriers to telehealth attendance, perhaps explore a hybrid follow-up model, and study whether motivational interviewing actually helps sustain better oral health outcomes in a clinical aspect and setting. And I want to take the time to go over my acknowledgements. Thank you so much to my mentor, Dr. Starr. I couldn't be here without you. Thank you so, so much. DT Research Fellowship, Dr. Behrens, Roger Mraz, Jessica Snyder, UCSF Pediatric Dentistry faculty, staff, and residents, the PPP students, Annie Yang, who actually started this project last year, if some of you remember her presentation, and Bonnie McDonald, who was our MI trainer. And those are my key references as well. And I'd be happy to take any questions if time permits.
Hi, Kimia. Thank you so much for that really informative presentation. I was also shocked by the completion rate results. So I think you touched on this a little bit, but why do you think the telehealth group had lower completion rates?
So I mainly think that telehealth had a lower completion rate because of technology access and issues with maybe families not knowing how to use Zoom necessarily, or issues with scheduling. For me personally, when I was calling the patients and trying to get them in the schedule, and we also included Spanish-speaking patients in the study, I did use the UCSF translator on the phone, and sometimes that would be a little bit difficult to completely translate and help get those appointments scheduled. So following up and making sure families actually attended their visits was a little bit difficult. But that's definitely something we'd want to further explore and assess and ask families in the future. Thank you for your question.
I have one real quick one.
Yeah.
Did you have a set up confirmation of these appointments the same way for both groups?
Yeah, so it was all through Epic, so there was those Epic confirmations, but I also did text via Google Voice the telehealth ones, and I sent them the Google Voice link, the telehealth Zoom link through Google Voice. Sometimes I get a response, but sometimes I wouldn't. Yeah.
Thank you, Kimia. It's my pleasure to introduce the next presenter, Dr. Diana Nguyen. She's a Health Science Associate Clinical Professor and Chief of the Division of Clinical General Dentistry at the UCSF School of Dentistry. After graduating from Columbia University and receiving her Doctor of Dental Surgery degree from NYU College of Dentistry, she completed a general practice residency at Yale. She is Fellow of Academy of General Dentistry, American College of Dentists, International College of Dentists, and Pierre Fauchard Academy, as well as a published author and nationally recognized speaker who has been quoted in Wall Street Journal, Forbes, and the New York Times. Dr. Nguyen currently serves on the board of directors for the San Francisco Dental Society and is a faculty ambassador for the American Dental Association. In 2024, she received the Gates Award for the Junior Faculty Achievement in Oral Health Education from the American Dental Education Association and Adia Gates Foundation, and she's presenting as part of a spotlight on clinical excellence. And title of her presentation is Clinical Education as a Catalyst for Leadership Development.
Oh, phew. All right, good morning. Hello, everyone. Thank you so much for having me today. I can't tell you how excited I am to have been invited to be here and speak with you this morning. So thank you to the Research and Clinical Excellence Day Committee for allowing me to share the stage with some of the most brilliant and accomplished and impressive minds that I have ever had the privilege of seeing up close. To the first and second year dental students sitting in the audience today, I am delighted to be here. And I look forward to welcoming all of you to the pre-doc clinic for the next phase of your hands-on clinical training here at UCSF. As Chief of Clinical General Dentistry, I oversee clinical operations across all of our group practices and also help to support faculty development and work closely with our students to ensure that their clinical experience prepares them to deliver exceptional patient-centered care. So, when we talk about clinical excellence, it's often framed in terms of precision, technical expertise, or adherence to evidence-based protocols. And all of those are very important, of course. But what I've come to realize over the years is that clinical excellence is also a pathway to something bigger, developing leaders. Every decision we make in the operatory, from interpreting radiographs to managing patient expectations, is also an exercise in leadership. And if we choose to reframe clinical education through that lens, then every patient encounter then becomes a training ground for the next generation of leaders in the dental profession. So today, I'd like to share a few examples and innovations that illustrate how this plays out in our clinics and how it prepares our graduates not only to be excellent clinicians, but also visionary leaders who can inspire teams and transform the future of oral health. I'd like for all of you now to travel back with me to the year 2010. This is a patient that I treated when I was a dental student. I still remember the first appointment. 33-year-old female who presented to the clinic with a chief complaint, I just need a cleaning. All right, be honest. How many of you looking at these photos up here are thinking to yourselves, just a cleaning? Lady, are you sure about that? I will admit, as a student, this case terrified me. In that moment, sitting across from her, I felt completely overwhelmed and totally unqualified to help her. It forced me to really wrestle with some very humbling questions. Like, what do I actually know about what's going on inside her mouth? How can I be sure that what I recommend for her is going to be the right treatment? And why do her gums look so angry? Looking back on this case now, I can see that it wasn't just about getting through a comprehensive exam. It was my very first lesson in healthcare leadership. As this patient's new primary dental provider, that meant taking responsibility for making accurate clinical diagnoses, guiding her to accept my treatment recommendations, and taking ownership of the outcomes of her care. Think for a moment about what our students do every single day in the clinic. They look at the x-rays, in the mouth, they take measurements, they read test results in the patient's chart, and they try to pinpoint what's wrong or what could be improved. They review those recommendations with a faculty member, defending the rationale behind their recommendations and thinking. And they explain it to the patient. They agree on a treatment plan, and then they get to work to carrying it out. To put it very simply, their clinical workflow is diagnosis, then communication, decision, and then action. But if you zoom out, you realize that it's also a workflow for leadership. Making a diagnosis requires analysis, weighing evidence, making sense of complex data. Communicating that diagnosis requires empathy and clarity. Deciding on a plan requires judgment and accountability. And taking action requires courage and follow-through. One of the most powerful arenas for developing leadership is communication. It's easy to give good news, but much harder to sit across from a patient and tell them that the treatment they need, or that they need treatment that they weren't going to be expecting, or that the care will take longer, cost more, or involve risks that they may not be comfortable with. Our students and faculty navigate these conversations daily. They encounter patients with different levels of health literacy, expectations, and sometimes very different ideas about what their care should look like. To succeed, clinicians need to practice compassion to see the situation from the patient's perspective. They need fluency to distill technical information into something a non-dental person can understand. And they need adaptability to shift their message based on the patient's background, language, or concerns. These aren't just clinical skills, they're leadership competencies, and our dental clinic is one of the best classrooms in the world to practice them. That's where our faculty come in. We're not just checking preps or signing off chart notes, we're coaching future leaders in healthcare. Think of all the times that you've watched someone stumble through explaining something or freeze when they realize that they don't have all the answers. When that happens in our clinic, our role as faculty isn't just to correct them, it's to model resilience, critical thinking, and empathy. We create a safe space for our students to think critically, ask questions, and reflect thoughtfully on what every patient interaction can teach them. And when they succeed, we celebrate not just the injection that they gave or the crown that they seated, but the confidence, judgment, and professionalism that they demonstrated at every step along the way. Teaching effective patient communication is at the heart of leadership development in clinical education because the same skills that make someone a strong communicator with patients are the ones that make them an effective leader. When students learn to listen with empathy, explain with clarity, and build trust with their patients, they're also practicing how to motivate a team, de-escalate conflict, and create alignment, the core functions of leadership. Communication in the clinic isn't just about delivering information, it's about connecting with people in moments of vulnerability. That's what leadership looks like. It's emotional intelligence in action, being able to read the room, adapt your tone, and help others feel seen and understood. And so for our faculty, teaching communication means modeling it ourselves, giving feedback that's specific and kind, guiding students through difficult patient interactions, and demonstrating that professionalism is not just about what you say, but how you say it. All right. Now, even with dedicated faculty modeling leadership, empathy, and resilience for our students, the truth is that there are times when the system itself can face incredible strain. Coming out of COVID, we had far fewer faculty and administrative support than before. The doctors who were left were balancing heavier teaching loads while also learning how to navigate EPIC, our new electronic health record system. And at the same time, our learners were facing uneven clinical exposure and difficulty accessing those resources equitably. So with the critical faculty shortage and reduced staff, we had to get creative to meet the challenge of continuing to provide our learners and their patients with the best experience possible. So we had to ask ourselves, how do we leverage what we already have? The solution was to tap into the leadership potential of our most high-performing fourth-year students, those who'd consistently demonstrated clinical excellence, sound ethical judgment, team player mentalities, and the ability to communicate effectively and clearly. We designated these students as D4 chiefs within their group practices. This innovation started as a small experiment in just one group practice, mine, and ultimately grew into a program that was adopted across all of UCSF's group practices within 2 years. D4 chiefs are real-time, in-clinic resources for their peers. They jump in to assist chairside with a challenging patient, troubleshoot issues that their fellow students are having with EPIC, and support strategic scheduling coordination. Most importantly, they model best practices to the students around them. Their presence helps to create a sense of shared ownership and accountability in their group practice. The outcomes are immediate and meaningful. More collaboration and peer-to-peer learning. A clear point person or persons for technical and logistical support when attending faculty are busy helping other students. And a tradition of clinical excellence led by students who inspire others to rise to the same standard. The D4 Chiefs initiative is built around 3 simple but powerful steps: engage, entrust, and elevate. See what I did there? All right. First, we engage. At UCSF, students are assigned to their group practices in their first year. That means, as group practice leaders, GPLs, we know from the start which students we'll be mentoring throughout their clinical journey. I use this early window to identify students with strong potential, those who have already demonstrated leadership, a collaborative spirit, and an outstanding work ethic. And I begin investing in them long before they've treated their first patient. So yes, D1s and D2s, I am watching you. Next, we entrust. By their 4th year, these students are appointed as D4 chiefs, and they play a hands-on role in supporting their peers, attending faculty, and the clinic operations team. They act as a bridge between students and leadership, supporting day-to-day clinic operations, reinforcing professional standards, and helping to identify and resolve challenges early. Working closely with faculty and the GPLs, they ensure that the clinic runs smoothly while modeling the collaboration and accountability that we expect from future dental professionals. Finally, we elevate. We make sure that these students are recognized for their contributions, not just with the title, but by creating a sense of ownership and purpose that lasts beyond graduation. Here's a former D4 chief who came back to UCSF as an immensely popular and productive part-time instructor. I make it a priority to invite outstanding chiefs who performed brilliantly as students to return as faculty and continue to nurture them as clinical educators. Our students look up to them as role models who have been in their shoes and are now giving back to UCSF. This is humanistic dental education in action. It also creates a pipeline of future faculty and a succession plan for our institution, not just for strong students, but for future leaders in dental education who already feel deeply connected to the mission and values of our school. When we talk about clinical excellence in the pre-doctoral clinic, it's not just about the quality of a single procedure. It's about the culture that surrounds the care that we provide. The D4 chiefs have been a critical part of shaping that culture. First, their presence sets a tone. These are students who exemplify strong clinical judgment, professionalism, and ethical decision-making. By modeling those qualities, they raise the bar for everyone else around them, not through authority, but by example. Patients and students can see and feel that clinical excellence isn't some abstract concept that we're trying to achieve. It's already here because our chiefs are living, breathing, and upholding it through everything that they do. Second, the role itself develops real-world leadership and communication skills. Chiefs learn how to navigate clinic dynamics, manage patient flow, and serve as a bridge between faculty, staff, and students. Those skills directly support clinical excellence because a well-coordinated clinic is one where patients are seen on time, emergencies are handled smoothly, and students feel supported rather than overwhelmed. And third, the chiefs promote true team-based care. Their leadership has created an environment where students share knowledge, step in to help one another, and problem solve together. The result is a clinic that runs more efficiently and feels more collaborative, which mirrors the team-based care models that our profession is moving towards. So in short, the D4 chiefs don't just help the clinic function, they help it to thrive. Their impact is reflected in the mentorship that they provide, the leadership they practice, and the culture of excellence that they inspire. Let's talk about an obstacle to achieving clinical excellence, the struggle to serve walk-in patients and those who are stuck waiting weeks or even months for an appointment. Sure, some patients come in without a scheduled appointment because they're looking for convenience, but honestly, most of them are looking for relief. Until recently, even when students were technically available, the front desk had no reliable way of finding them. Staff were too busy to search the clinic to track down an available provider, and sometimes a student who looked open on the schedule had already packed up their chair because they had no patient booked and nothing to do. So for patients, the odds of being seen for an emergency were pretty low if you weren't one of the very first people to walk in at the beginning of the day. And likewise for students, if you weren't pre-assigned to take emergencies at the start of the clinic session, you often lost out on opportunities to grow your patient roster and gain more clinical experience. This is our student clinic at the dental center. 1 floor, 80 chairs, divided into 5 distinct group practices. Under our previous system for walk-ins, each group practice had just 1 chair designated for taking unscheduled emergency patients during each clinic session. Once those were filled, there was no clear way to know if anyone else could be seen, whether they were in pain, hoping to establish care, or frustrated after phoning the call center and hearing about our long wait times. And every time we had to say, "We're sorry, but we've reached our capacity for today," it represented a real missed opportunity, not just for patient care, but for education. Students were losing out on teachable moments in diagnosis, triage, and communication. We knew that we had to disrupt the system and come up with something better. So in April 2025, we reimagined, redesigned, and launched a new system designed to shift from scarcity to patient-centered access. We set a goal to see every patient who walked in, whether it was urgent or not. Under this initiative, we were leading patient care with an entirely new mindset, which is that nobody gets sent away without every single person in this clinic doing everything they possibly can to help them right away. We created a centralized communication hub where group practice leaders and D4 chiefs could coordinate in real time with staff in our dental center lobby and the front desk. So this allowed faculty leaders to quickly match match our walk-ins to students who had same-day cancellations, patient dismissals, or upcoming availability. By making this process faculty-led with the support of our D4 chiefs and our spectacularly dedicated staff, We not only improved efficiency, but also ensured that patients were connected to students who needed clinical experience and wanted to help, creating a win-win situation for everyone. The system maximized chair utilization, ensured that our resources didn't sit idle, and conditioned our students, faculty, and staff to not only be prepared for last-minute additions to the schedule, but to expect and aim to manage more than one patient per session, a critical skill for anyone working in residency, private practice, community health, and any other clinical setting that our students might find themselves in after graduation. So what was the impact? In just under 6 months, the new system has now accommodated over 2,000 same-day patients, a dramatic increase from the past. But the numbers only tell part of the story. This new workflow modeled adaptability, teamwork, and a commitment to serving patients first. So we're not just performing procedures, but designing systems of care that are equitable, efficient, and patient-centered. So now our students are leaving UCSF with those lessons programmed into their professional DNA. When we launched the new walk-in patient process, it wasn't just an operational change. It was a leadership exercise at every level of the clinic. For our students, it required adaptability, communication, and confidence. They had to think on their feet, triage patients, and collaborate with their peers and faculty to make real-time clinical decisions. And that meant developing judgment and teamwork skills that go far beyond what you can learn from a scheduled appointment. For our staff, it was an exercise in coordination, communication, and systems thinking. Managing unpredictable patient flow meant everyone had to stay aligned and proactive, not reactive. And for our faculty, this process called for trust and coaching rather than control. It pushed us to model calm under pressure, demonstrate situational leadership, and create psychological safety while still maintaining efficiency and high patient care standards. In other words, the walk-in system didn't just expand access to care, it expanded our leadership capacity. Every person in that process, from front desk to faculty, had to demonstrate initiative, accountability, and a commitment to our shared mission. So ultimately, this project helped to strengthen the muscle of leadership across clinic, leading through uncertainty, collaborating across roles, and staying focused on patient care outcomes, even when the path wasn't predictable. Over the course of my career, I've had the privilege of teaching, learning from, and collaborating with hundreds of scholars and clinicians. And what I've learned that is in dentistry, success is never just about the metrics or the data points. Excellence isn't measured in the number of procedures you've completed or how quickly you can get your patient in and out of the chair. It's defined by something so much deeper. The connections you make, the creativity you demonstrate, and the compassion that you apply to every patient interaction. Leading others to success, whether it's in patient care, education, or research, is rarely comfortable. It asks you to step into uncertainty, to make decisions without perfect answers, and sometimes to stand apart from the crowd. But within that discomfort lies the possibility to reimagine what's possible and to find solutions for the people who need it the most. Every time you care for a patient, you lead the way, and often a team, towards clinical excellence. And when you multiply that across every time you step into an operatory, you realize that you're constantly playing the role of a leader, even if you don't realize it. Our graduates are entering a profession that's more complex than ever, balancing patient care, team management, compliance, technology, and often while they're teaching or running practices of their own. Technical skill alone isn't enough to navigate that landscape. Leadership is what helps clinicians communicate across disciplines, adapt to change, and make sound ethical decisions under pressure. It's what bridges the gap between knowing what to do and guiding others to do it with confidence and compassion. You know, historically, the spotlight on clinical excellence lecture has always been given by an experienced, actively practicing clinician, someone who's asked to share examples of their own patient care, pictures and radiographs and images that make the audience go, wow. Cool cases, complex procedures, the kind of work that makes you sit up a little bit straighter and think, oh man, that's what excellence really looks like. And the way it's set up, it sort of makes you believe that clinical excellence is this label that's only reserved for the best of the best, something that you have to chase until you feel good enough, accomplished enough, and experienced enough for people to look at your work and say, I need to get myself on that level. So here's the part that I'm really not supposed to tell you. Clinical excellence isn't a destination. It doesn't exist anywhere on a map. You don't just get there and then you're done. At its core, clinical excellence is a mindset. You unlock it, and it motivates you to help continue to refine your skills, refresh your knowledge, and deliver the best possible care that you can because you believe that your patients deserve nothing less. The mindset, that mindset, is what separates good clinicians from great ones. And it's also what defines a leader. Because leadership in dentistry and healthcare isn't about standing above others, it's about standing beside them, setting the tone through your actions, and leading by example. I'd love to continue this conversation with all of you, but we all have to go to lunch. So I hope to hear about your experiences, your perspectives, and your questions. So please be sure to connect with me and say hello at some point today. Thank you so much.
Okay, I think we're going to have to start because it's officially 1:30 now. So I'm going to have UCSF Innovation Ventures come up and tell you and reveal the insights.
Yeah, so thank you very much. My name is Amy Greishuk. I serve as an associate director within UCSF Innovation Ventures. And I want to thank the organizers for just a few minutes to say a few things. Innovation Ventures is a division within the Office of the Executive Chancellor and Provost at UCSF. We are dedicated to promoting innovation and commercialization of research and technologies developed within the university. David Morris serves as the Vice Chancellor of Business Development and Partnerships. He's joined by Peter Katsonis for Health Tech Commercialization and Einor Sawyer for Innovation and Entrepreneurship. And within our group, we are dedicated to becoming a partner of choice for UCSF. So that's why we're here. We want to let you know about us and that we are a partner of choice for the community, for the investors, and supporting UCSF early career innovators and entrepreneurs. Within health tech commercialization, we work with the UCSF community as you have new invention disclosures. So if you're innovating and you have something exciting you want to let us know about, please reach out. We then perform market assessments, we develop intellectual property strategy business models, and we make connections to investors and partnering organizations. And then we manage industry partnerships. There's a colleague that was at the seminar session, Alex Kiatz, and she and I are in attendance today within that health tech commercialization unit. And we focus on alliances where we want to foster, facilitate, and support these industry engagements and sustainable partnerships. Our strategic alliances mission is to identify mutually beneficial collaborations and strategic partnerships. Thank you.
Hi all, my name is Samuel Choksi. Thanks for coming back from lunch. I'm going to be chairing this afternoon session. I'm a new assistant professor in the Department of Cell and Tissue Biology. So this is like a really wide array of exciting research that I'm learning a lot about with you guys as well today. So we're going to kick off the afternoon session, which is going to range from early mouse embryo development all the way to public health research. And we'll start with the nasal pit. And our first speaker is Luke Lucido from Jeff Bush's lab. Welcome up, Luke.
Alrighty, good afternoon, everybody. Welcome back. My name is Luke Lucido. I'm a D1 and part of the Oral and Craniofacial Sciences graduate program. Very happy to have the opportunity to talk to you a little bit about my thesis work done in the Bush lab titled Nasal Pit Invagination, a Novel Morphologic Contributor to Cleft Lip. So cleft lip represents the most common craniofacial birth defect worldwide. And clinically, it can present in a variety of ways. And this kind of reflects the multitude of different causes that can stem from both genetic causes or environmental that can lead to this phenotype. And this, in part, is why it's still not completely understood, the underlying etiology of it. But what we do know is that it normally involves the failed fusion between the medial nasal process and the lateral nasal process. And this fusion takes place from late embryonic day 10 in mice and completes by embryonic day 12.5 when those those separate processes have become one. And we initially started this project by investigating the role of TGF-beta receptor 1 in this fusion. TGF-beta receptor 1 has a known role in secondary palate formation. Additionally, there's been variants associated with the gene found in humans with cleft lip, and as well as when our collaborator broadly knocked out TGF-beta receptor 1, both in the mesenchyme and in the epithelium of the craniofacial processes, it resulted in bilateral or unilateral cleft lip. So our first question was to answer in what specific cell type TGF-beta receptor 1 was needed during this process. So we utilized CREACT to conditionally delete TGF-beta receptor 1 specifically within the craniofacial epithelium seen here in green. And that resulted in 100% penetrant cleft lip by embryonic day 12.5. But when we look early at this, when we can first see this phenotype, we can see already a discernible changes to the nasal processes structure or architecture prior to when this fusion is initiated as early as embryonic day 10. So what happens before this fusion event? Prior to fusion, or prior to there even being a medial and lateral nasal process, the face consists of one large frontal nasal prominence. And these special cells that comprise the nasal placode will then invaginate or fold in on themselves to separate the frontal nasal process into the medial nasal process, the lateral nasal process, and form the nasal pit between the two structures. So when we take a closer look at this process, first in just a wild type setting, we can see that as the nasal placode forms initially, it then invaginates or folds in and continues over this next couple hours to form this nice tight concave structure. But upon loss of epithelial TGF-beta receptor 1, we see that while this placode initially forms, it really loses the degree of curvature or invagination that this epithelial folding that takes place that really prevents the distal ends of the nasal processes from making proper contact and ultimately fusing. But what's happening at a cellular level? So when we look at proliferation by incorporation of EDU, we can see a very highly localized change or reduction in proliferation at this pit center or nadir that serves as kind of the hinge point during this folding process. And we can see a statistically significant decrease both in the mid-pit and the anterior in this nadir area. But we must remember that, so what are the cells in this pocket, in this nadir? This is not just a simple epithelium that's folding. It's a sensory placode that's ultimately going to give rise to all the neurons and all the cells that are going to comprise your olfactory system. And these cells are rapidly proliferating and starting to differentiate along this pathway concurrently with nasal pit invagination. So when we look at these immature olfactory neurons as they're beginning to differentiate in this setting, we can see a decrease or alteration in their formation, as well as an increased cell death marked here in yellow upon loss of epithelial TGF-beta receptor 1 in this same pocket or area that we saw this localized reduction in proliferation. And all that together has led to our current model that upon loss of TGF-beta receptor 1, we get a very highly localized reduction in proliferation. And secondarily to that, we see this increased cell death, we see alterations in olfactory neuron formation, and those together are causing a decreased folding of this nasal pit epithelium that does not allow proper contact between the nasal processes and ultimately leads to cleft lip. That is to say, we are continuing to explore this both at the molecular level to better understand TGF-beta receptor 1's role both on a cellular and tissue scale level. We really need to dissect the signaling pathway acting both upstream and downstream of it in this context. So we have a number of different approaches to try to get at this now that I won't get into, but just to say that there's more work going on. This is a very complex signaling pathway. And of course, this is not a solo project. We have a great group in the Bush Lab that have all contributed to this project, and I'm very thankful for all of you. Would like to acknowledge, the Department of Cell and Tissue Biology, the program in craniofacial biology, and the OCS graduate program, as well as my funding. And any questions?
It's so intriguing in terms of the embryogenesis, and I think a lot of that actually Gail Martin's work last 50 years in terms of gradients of signaling. Do you see a gradient as you see this? The fusion is there. So the kinetics of this. Have you looked at those really easy things to look at? I'm kidding.
No, we haven't really looked exactly at that. We think that the receptor is everywhere throughout this epithelium, but we haven't done that stain. Based off these very highly localized changes, we think we really are getting at that pocket of cells. So I think it's worth further exploration. Some things like some live imaging or some Fuji mice that we might be able to track that proliferative changes, or even like a Chase EDU, BRDU. We're hoping to get at that, more like that time point of it.
It'd just be good to look at some activity assays too. If you could look at the signaling,
Mm-hmm.
Maybe while the next speaker, Deborah Tan, is setting up, I can ask a question. Do you guys have an idea of where the source of the ligand is, where the TGF-beta is coming from?
No, we do not. But we have some TGF-beta receptor 2 knockout mice that don't recapitulate this phenotype. So we don't think it's TGF-beta 1, 2, or 3 as the upstream ligands, or not at least just solo them. So we are looking at a lot of those non-canonical pathways right now to try to see if those are, and we also have a single cell data set to try to kind of reverse engineer it to see what ligands could possibly be activating it.
Very exciting. Mm-hmm. Any more questions? Okay, let's thank Luke again.
Thank you, guys.
Our next speaker is Deborah Tan, and she's from the Hablitz and Desai Labs. And she's going to tell us a little bit about novel ways of drug delivery for modulating osteogenic stimulation. Thank you, Deborah.
Hi, everyone. Thank you for the introduction. My name is Debbie Tan, and I look forward to sharing my D2 fellowship project with all of you. So millions of people worldwide are affected by craniofacial bone defects. This can be due to factors such as severe trauma, removal of malignant tumors, and systemic diseases like osteoporosis. So conventionally, these are repaired with autografts or allografts, but both have their own limitations, leading to the creation of synthetic bone grafts. However, these are still restricted in healing larger defects, which is why we are here today to discover how we can improve biomaterials for bone regeneration. So now when our bone tissues are old or damaged, they can undergo bone remodeling. So this is maintained by a balance of osteoclasts, which resorb bone, followed by osteoblasts, which build up new bone matrix. So an imbalance in this, such as elevated osteoclasts and systemic diseases and trauma, can result in bone loss and delayed healing. So to combat this, our group has been interested in using osteoprotein fusion protein, or OPG, to inhibit osteoclasts. So when our body wants to resorb bone, osteoblasts produce RANK ligand, shown here in blue, which binds to the RANK receptor on pre-osteoclast, resulting in osteoclast differentiation. On the other hand, when we want to stop bone resorption, our osteoblasts will produce OPG, which acts as a decoy receptor to block this RANK ligand RANK signaling and cause osteoclast apoptosis, shown here. However, all of the current strategies have been using stem cells to overexpress OPG or dosing strategies that can give rise to elevated systemic levels, which is why our group wants to develop a way to control and optimize OPG release for proper bone healing. So our lab has been interested in creating these hollow hydroxyapatite microparticles, which are porous and can serve as a drug carrier for OPG. So we made these from a calcium carbonate template and etched away the middle to produce this hollow core in pH 9 and pH 11 solutions. So we named pH 9 coarse and pH 11 needle based on their surface topography. So first we wanted to see how these particles were interacting with cells. So here, osteoblast nuclei are stained in blue, their actin cytoskeleton is in red, and our particles are stained in green. You can see here that both the particles are kind of embedded inside this actin cytoskeleton, strongly suggesting that they're interacting with cells. So then we loaded these particles with our osteoclast inhibiting drug, OPG. So on the left, you can see how much OPG was loaded for the two particles, showing its high loading capacities, and which are not typically seen with traditional solid particles. And then on the right, you can see that the particles have very prolonged release, lasting over 40 days. But when we take a closer look, more than 50% of the protein is being released within the first 5 days. And almost all the protein is being released within those 40 days. So this fast release isn't as ideal because the effects of OPG can decrease quickly with time. So, which is why we want to create this long-term delivery system with slower release for more optimal results. So how can we do this? How can we further modify our particles to control drug delivery and improve bioactivity? So the method I propose is by modifying these particles with a mineral layer known as ion doping, specifically with strontium ions, which are known to stimulate osteoblast differentiation and inhibit osteoclast formation at the same time. So after loading our drug OPG, I incubated these particles in a supersaturated ion solution to coat its surface, forming a layer around the hydroxyapatite shell. So I propose that this modification can slow down the release of OPG for a more optimal drug delivery while at the same time increasing its bioactivity. So after coating these particles with strontium, I wanted to see if it would alter any of the original properties. So here's both the course and needle without any strontium coating. And when we added our strontium coating, you can see that both the particles were able to maintain their original surface topography and the hollow core is still maintained. Then I wanted to check its drug release. So as we saw before, all the OPG was being released within the first 40 days for the course and for the needle. However, when I added my strontium layer on, the particles significantly reduced their drug release, with only 20% being released in the first 40 days. So this is an 80% decrease from before, and ideally the slower, more long-term release can make OPG more effective. In addition, I also measured the calcium release or dissolution of the particles over time. So before, the needle and course had very little calcium release, and after I added the strontium layer, you can see that there is much more calcium release, over 10 times compared to before. So adding this additional layer can create enhanced dissolution of the ions, which can make a more favorable environment for osteoblasts to grow to. So after optimizing these particles, I wanted to confirm the drug we loaded OPG is still effective. So here we treated bone marrow-derived osteoclasts and used trap staining to stain it pink. So you can see here on the left are our control groups with rank ligand and induced osteoclast formation, forming these large pink multinucleated cells. No rank ligand, there's no staining, no differentiation happening. And with treatment with only OPG, there's reduced osteoclast formation. When I added my particles with it, you can see that in each of these So after I added the particles without OPG, you can see that while there's still osteoclast present here, the size of the osteoclast itself decreased overall. So larger osteoclast cells have more resorptive activity since they can cover more surface area. So a decrease in the size here indicates that it can be reducing its activity this way. So when I treated these cells with my OPG-loaded particles, you can see that each of these treatments here, there's a reduction in trap staining, showing that the OPG is being released by the particles and having an effect on the cells. These images actually look very similar to our control group on the left with only OPG treatment, showing that an effect is happening. So next, I counted the osteoclasts in each of our images. On the left are the osteoclasts treated with the coarse particles, and on the right are the needle. So based on these numbers, I saw that there's still osteoclasts present after particle and OPG treatment, except for our coarse strontium doped particles with OPG, which did show very little osteoclast activity. But overall, the numbers didn't seem to be changing the osteoclast as we expected, but they did seem to be changing its size and trap activity as we saw in our previous images. So we still need to run further experiments to fully validate these results. So overall, these particles represent a highly promising and tunable biomaterial as drug delivery systems in bone regeneration. By further modifying them with a strontium coating, we can observe a slower, more sustained drug release and increased calcium release. Although the particles didn't seem to reduce osteoclast numbers as we expected, they can reduce its size and decrease trap activity with OPG release. So for future studies, we aim to measure osteoclast sizes, osteoblast gene expression, as well as evaluating the regenerative capacity of these particles with in vivo treatment in animal models. Thank you all for listening to my project. I'd like to end by thanking Roger and Dr. Behrens for the D2 Fellowship, my co-mentors, Dr. Hablitz and Dr. Tsai, as well as Darnell Kyler, who dedicated his time to mentor me throughout my project. Does anyone have any questions?
Thank you. Great presentation. I was curious, why do you think the strontium particles had reduced drug release?
Yeah, that's a great question. Here. So you can see in these images here that for our strontium particles, the reduction in drug release can be due to the additional layer specifically. So when we created these particles, we loaded it with OPG first in its hollow core and throughout the hydroxyapatite surface. And then we added the additional layer of strontium on top of it. So we believe that this release data, the slower, more sustained release that we're seeing, could be due to the strontium ions being released first, then followed by OPG release. Thank you. Any other questions?
I'm curious.
Yeah.
You showed us strontium ions. Have you guys tried any other positively charged ions? And do you think they would work as well or very differently than strontium?
Yeah, so we were specifically interested in strontium because is known to have a dual effect on osteoblasts and osteoclasts specifically. So strontium can work very similar to calcium and increase osteoblast gene expression and also inhibit osteoclast formation. So that's why we focus specifically on strontiums. But we're also, I think it will be interesting to look at further experiments too, looking at other ions.
All right, let's thank Debbie again for a really nice talk. And our next speaker is Vasif Qayyum, and he's working with Dr. Kamal Al-Eriani, and is going to tell us about floating teeth today.
Good afternoon, everyone. My name is Vasif Qayyum, and I'm a second-year resident in oral medicine. As clinicians, we are here to treat infections, but what happens when an infection refuses to heal? Today, I'll share a case that challenged that assumption, a floating tooth that revealed a hidden malignancy and a powerful lesson in clinical interpretation. I declare no conflict of interest. So if we look a little bit about the background of floating teeth, a floating tooth describes a radiographic appearance where a tooth seems suspended in air with little or no supporting bone around it. You will see this in infections like osteomyelitis, but also in malignancies like Langerhans cell histiocytosis, and also in intraosseous squamous cell carcinoma, lymphoma, or even metastasis. The key features: ill-defined or scooped out bone loss or cortical breach, and most importantly, failure to respond to antibiotics. When there are failure to respond to antibiotics, this is the time then we must pause and think, could we do something more? For example, a biopsy. If you see, there are few cases, rare cases, scattered across the literature, often single case reports. That rarity is exactly what makes them dangerous. Most clinicians only see few cases throughout their life. So we need awareness, because early biopsy can mean the difference between life-changing surgery and life-saving intervention. Let's quickly see what are some of the differential diagnoses. So let's quickly review. A floating tooth might represent as an infection, which may be a moth-eaten bone or sequestra, or maybe as an Langerhans cell histiocytosis, you can see scooped up defects, often multiple. Squamous cell carcinoma, of course, can be presented as ill-defined or poorly defined lysis, cortical breach, and soft tissue mass. So here comes our case. Our patient was a middle-aged woman, immunocompromised after a hematopoietic cell transplant. She presented with pain, swelling, and purulent discharge in the lower left jaw. Tooth number 18 had been extracted and an implant removed from tooth number 19. Yet the symptoms persisted despite multiple antibiotics. That's the first red flag. Infection that doesn't heal with antibiotics. Based on the patient's representation, we made our differential diagnosis. Our initial differential diagnosis included infection, lymphoma, leukemia, or maybe squamous cell carcinoma. Given her history and poor healing, we performed a macrooral swab and ordered a CT scan for the patient. Remember, in oral medicine, our job is to think broadly before thinking deeply. Every chronic non-healing site must be viewed with suspicion. Here are the imaging and labs of the patient. So CT scan imaging didn't show classic signs of osteomyelitis or no drainageable abscess or significant sequestration. But radiographically, the bone destruction around number 20, which you can appreciate here, the bone destruction can be seen, especially on the buccal cortical plate, which you can see is much more affected than the lingual cortical plate. And here, tooth number 20, which you can appreciate, is floating around. When imaging and clinical findings don't align, that's your clue. It's time for a biopsy. The biopsy for this patient was a turning point. The initial sample which we took hinted at dysplastic change, and you can see severe epileptical dysplasia and non-vital bone in this patient. So the biopsy actually revealed this basal cell layer, cellular atypia, and also the varicose pattern of the epithelium throughout, and parakeratinized epithelium at the top. Also, there is hyperchromatasia in all these, and the cell size is different, again indicating towards something going towards more severe. And the diagnosis based on the P53 gene expression, which shows not a wild type, but evenly distribution and picking up of the expression throughout of P53 throughout the cells. The patient was treated with definitive resection. And on resection, you can see that the depth of the tumor was almost 17 millimeter, and this tumor actually is advancing into the intraosseous area as well, involving the bone. The patient underwent a segmental mandibulectomy, pre-fibular flap reconstruction, and net dissection, followed by chemoradiotherapy. Post-operatively, she recovered well with no recurrence today. It's a powerful example of how timely diagnosis and multidisciplinary care, surgery, oncology, and oral medicine come together to resolve both health and hope. The key takeaways of my presentation is a floating tooth as a radiographic sign, not a diagnosis. Non-response to antibiotics, persistent discharge, or ill-defined bone loss should raise concern and prompt an early biopsy. Always include malignant conditions such as intraosseous squamous cell carcinoma, lymphoma, or metastatic lesions in the differential diagnosis. This case taught me that our greatest responsibility is not just to treat, it's to question. And I think this case make me to ask better questions in this way. Thank you very much for your attention. And thank you. I want to thank my mentor, Dr. Kamal El-Ariani, my senior, Dr. Khushbu Gupta, and especially Dr. Richard Jordan and Dr. Krishnan for providing me with the pathology slides. Now I'm open to your questions. If you have any questions, you may ask.
I have a question. Did you, at the time of biopsy, did you take number 20 out? And then where did you take the biopsy from?
The biopsy was taken from the intraosseous area. So we took the biopsy from number 19 region.
19?
Yes, number 19 region. So patient actually came with a complaint that from the number 18 and number 19, 2 months before visiting the oral oncology clinic. she developed infection. And because of the floating teeth, 18 and 19. So in 19 was an implant and 18 was a floating tooth. They pulled out both the tooths, the implant and the tooth. So the patient was on antibiotics but was not healing. And we started with them antibiotic as well, but haven't healed. So then we took the biopsy from number 18 and 19 region, intralesion.
And did you take out 20?
No,
20
we haven't
was the
took out
floating
20.
one.
We actually, the patient was referred further on for the surgery to OHNS then, later on. So they did all the treatment then. Yes, exactly. Yeah.
Any more questions? Okay, thank you, Vasid.
Thank you very much. Thank you.
Okay, next we're going to hear from Natalie Nassib. And she's going to tell us, she's working with Dr. Pamela Den Beston, and she's going to tell us about the development of the mandibular region in the mouse.
Hello everyone, my name is Natalie Nassib. I'm a D3 part of the Den Beston lab, and today we'll be discussing the geometric morphometric analysis of mandibular development in mice exposed to early life adversity. I'm sure you're all thinking, wow, that's a lot of words, which it totally is, so let's break it down. First thing is early life adversity, which results from environmental stressors for children and adolescents that may be going through things including poverty, neglect, and abuse, all of which have been known to increase cortisol levels and affect brain development as well as enamel development. So we thought, what if we look at the mandible as well? We used a limited bedding and nesting model, or an LBN model, that mimics these stressors in P2 to P12 mice. As you can see with the control mice, they have adequate bedding and nesting, and the experimental mice have low bedding and nesting, which is what allows for that increase in cortisol level, as well as fragmented and unpredictable care from the mother to the pups. As a result, we wanted to look at three specific things: the phenotype of the mandibular size and shape, the mandibular bone density, and then the bulk of our project is assessing these mandibular discrepancies using the geometric morphometric analysis of these mice mandibles, comparing the control to the ELA. So our first thing was the phenotypic comparison. Just visually, when we look at the difference between the control and ELA mice, we can see that it's screaming at us. It's different. The coronoid, condylar, and angular processes of the control mandible are much more defined than that of ELA, and we also see discrepancies in the height of the ramus and length of the body of the mandible. And this is really what inspired our project. Seeing this, we knew we wanted to dig deeper, so that's exactly what we did. We ended up collecting 14 mouse mandibles, collected on postnatal day 12, and we were able to scan these using micro-CT, convert them into DICOM files for 3D visualization using the Amira software. And then using Amira, we were able to filter, segment, and extract the mandibles in order to create this image that would allow for further analysis. We also wanted to look at the bone density, and we found that when we compare the control and ELA bone density, that the ELA mice seem to have a higher mean intensity than that of the control mice, which is similar to what was found in earlier research done with enamel. We used a masking range of 6,000 just to keep everything standardized when doing this comparison. But again, as I mentioned earlier, the bulk of our project was this geometric morphometric analysis, which is where I want to spend the most of our time. The first thing we did to get this analysis started was placing landmarks. We placed 19 landmarks using 3D Slicer, and the landmarks were standardized from the Penn State Skeletal Morphogenetics Analysis Lab. The reason we need these landmarks is to standardize. We need a standard way to look at the variation of shape and size differences of these mandibles. But we also need to be reliable, which is why we had two researchers, myself and Yuna, separately place these landmarks to ensure that we were placing them in the same spots. And we had a mean ICC score of 0.92, with the highest ICC score meaning perfection. Every single landmark was placed in the exact same spot, being 1. So 0.92 is pretty awesome. That means we have excellent reliability and reproducibility between our landmark placing. And then finally, we can get into this geometric morphometric analysis using these landmarks to align the specimen and compare the true shape differences across these groups. The first thing we looked at was the difference between groups and within groups. Let's kind of break down what these bars mean. Between groups is showing the differences among the groups, ELA versus control, as well as male versus female. Whereas within group is just thinking of it as individuality. Every mandible is going to be different, which is why that bar is so high. But to see if there's actually a statistically significant difference between these groups, we do between groups divided by within groups. And that's what gives us our F value of 2.70. And we also got a P-score of 0.001, indicating that this is not random. In fact, this is highly significant shape differences between groups due to this experimentation. In fact, it's almost a 3 times variation, which we get from that 2.7. So then we look a little bit further. We do a PCA plot of this mandible shape variation to see where exactly these variations are lying. And when we look at this graph, we can see that each color is representative of a specific group, green being control male, red being control female, and so forth. And each point represents one mandible with its position determined by its overall shape. We kind of see these clusters, which makes us wonder, is this just due to sex, or is this also due to the condition they were placed at? And we also look at the axes, and we see that PC1 represents the largest source of variation, whereas PC2 is the second largest source of variation. What does that mean? So we keep going, we keep digging, and we split it up into 3 different sections: sex, condition, and interaction. Sex represents male versus female, condition is ELA versus control, and interaction is the combination of the two, sex times the condition, sex with the condition. And we see that PC1 is specifically capturing differences when we look back at the landmarks in the mandibular length and the angle of the ramus. And we see that condition is the one that showed the strongest effect. I also want to note that the stars above the bars indicate statistical significance, whereas PC2 is looking at the link between ramus height and condylar region shape, and this one is both showing an effect with condition but also sex, indicating a sexual dimorphism there. When we look at humans, we see that human males typically have a greater mandibular length and angle of the ramus, which was represented by PC1. But in our mouse model, we saw that ELA alone was affecting these morphological parameters. In contrast, when we look at humans again, we do find significant sex-related differences in the ramus height and condylar region shape. And these differences were affected by sex, but were also further affected by ELA. This ultimately brings us to the conclusion of ELA is significantly altering the mandible shape, and that the effect of ELA is greater than sex alone, but sex is modifying how ELA is manifesting in this morphology. In terms of clinical significance, this is super important to us as clinicians because it allows us to understand how stress is impacting jaw growth, which allows us to affect our treatment and the way we look at patients. Specifically, determining the implications that a discrepancy in mandibular development could have on the potential of developing temporomandibular jaw disorder, as well as the effect that this could have on any orthodontic treatment in the future. In terms of future directions, we would love to look at the exact role of early life adversity in altering mandibular formation by looking at these gene pathways that it's targeting, whether that be FGF, Wnt, just something we would love to look into, and also seeing if this phenotype persists into adulthood. If we were to leave these mice to become adults, would their jaws go back to the way they're supposed to be, or would they remain in this strange variation that we're seeing? So those are just future directions we would love to take. And I just want to say thank you so much to my mentor, Dr. Dunveston, who I could not have done any of this without. Your support has been incredibly supportive, and I would not be here without her, as well as the support of Dr. Hong, Dr. Zhang, and Yuna, who helped me place the landmarks. Thank you all so much for your contributions. I appreciate you.
Hi. What made you want to kind of look into this in the first place? Is this a pattern that has been noticed among humans?
Yeah, that's a really great question. Actually, so the Dunveston lab was working on enamel first. And so they were working on enamel and found similar results that we did in terms of the bone density. They noticed that the bone density of enamel was greater in the ELA than control, which is honestly not what we hypothesized. We would think that bone density would be better in control because they're getting all that care. But if I go back to that picture that I showed in the very beginning, I would say that is why I wanted to do this project. this right here was just like screaming at us. I was like, whoa, we should definitely also take a look at the mandibles because these look super different. We were focusing so much on enamel. Why not also take a look at the mandible? And I just think in terms of early life adversity, that was just something that I was pretty passionate about because I've definitely grown up in environments where I've seen early life adversity affect people in my community. And so I just thought, I wonder how this affects the jaw as well, because I think I've seen a lot of how it affects the social factors and the psychological factors of life. And so why not see exactly how it's affecting the mouth as well? Yeah, thanks for that question. Yeah.
So you just use 3D slicer for putting up the points, or?
Yeah, I can explain more about like the softwares.
Mhm.
So I used Amira first.
Yeah.
Amira was used to extract the mandibles.
Segment, okay.
Segment and extract, exactly. And then I exported that data from Amira into
Okay.
3D Slicer. 3D Slicer was used to place all the landmarks.
Okay.
And then after 3D Slicer, exported everything again into Morpho-J to do the analysis, the geometric morphometric analysis.
Okay, sure.
Yes. Thank you.
All right, any more questions? Oh, we got one here.
On comparing the male versus the female mice, I understand there was a difference. What exactly, could you review what exactly, was it more in females, more in males?
Yeah, we'll go back to that slide. Yeah, so here's kind of where we're just looking at the capturing the differences of where exactly the landmarks are. We didn't necessarily do like the intense sexual comparison of like, oh, was it more in males or more in females? Because we were more so just doing an outline of, is sex even a part of this? So that's like a great direction that we could definitely take it into. We're looking specifically at males, comparing males and females. But comparing sex was actually something that just came up as we were working on the project. Our full intention was to look at ELA versus control, and then we started noticing differences between sex. And we were like, maybe we should like take a sneak peek at that as well. But we haven't done a full dive, which is definitely a direction I would love to take it in.
Thank you.
Of course, thank you.
All right, thank you, Natalie, for a very nice talk. And our next speaker is Abdullah Al-Tumairi, also working with Dr. Al-Ariani. And he's going to tell us today about the connection between hematopoietic stem cell transplantation and oral cancers.
Good afternoon, everyone. I am Abdullah Al-Thumairi, and today I will present our study title, Incidence and Risk Factor for Oral Cancer in Hematopoietic Stem Cells Transplant Recipient. First of all, hematopoietic stem cells transplant is a procedure in where a healthy stem cells transplant to replace a disease or a damaged one. And it's a life-saving treatment for patients who develop a blood malignancy as well as bone marrow failure, and have two types, autologous from patient on stem cells or allogenic from stem cells from a donor. However, as a survival continue to improve, many patients experience late complication, including GVHD and oral cancer. GVHD is a graft versus host disease in which immune reaction from a donor T cells attacking a patient tissue, and it mainly happen after allogenic transplant type, and it can be acute within the first 100 days of the transplant or chronic after 100 days of the transplant. And the most common organ that can be affected by the GVHD including skin, eyes, liver, and oral cavity. In oral cavity, it can appear as mucocele or lichenoid reaction, as well as erythema and ulcers. And here in the picture, you can see there is a lichenoid reaction in the lateral side of the tongue with the erythema, as well as in the lips with crusting and mucosal region, mucosal changes. And these patients always, when came to our clinic, have concern of developing oral cancer. And that leads us to our main question in this study, whether the hematopoietic stem cell transplant patients are in higher risk to develop oral cancer compared to the general population. And that was our primary objective of the study. Our secondary objective to describe where the oral cancer site happened in the oral cavity and to check if the GVHD have a contributing factor as well. So we conduct a retrospective study. We use both Patient Explorer and IMERS. We analyze over 4.3 million patients, and we found that among these 4.3 patients, that the oral cancer cases around 6,086, while patients who underwent transplant around 7,900. Among these 7,900 patients, we found out that there is a 31 patient who developed oral cancer after the transplant. And here, an example of the oral cancer that can happen in the oral cavity as indurated ulcers that did not heal within a week. And in the next few slides, we're gonna go in deep about these 31 patients. We're gonna talk about demographic as well as GVHD type, transplant type, as well as the oral cancer distribution. So when we talk about the demographic, among these 31 patients, we found that the majority of the patients were male and white. And interestingly, the majority of the patients had no history of smoking, almost 61%, while 36% had history of smoking. When we look to the transplant type and GVHD type, we found that among these 31 patients, the majority of the patients underwent allogenic transplant type, and the GVHD, the chronic GVHD, was the most common among these 31 patients, including 7 of the patients who initially started as acute GVHD. Later on, it's become a chronic. When we look to the oral cancer distribution, most common site of the oral cancer among these 31 patients was found in the lower lip and the tongue, followed by buccal mucosa. And when we look to the underlying malignancy, 45% of the patients was diagnosed with acute myeloid leukemia, and followed by multiple myeloma, then CLL, then other hematological disorder. So based on our risk ratio, we found out that hematopoietic stem cells transplant patients are in 3 times higher risk to develop oral cancer compared to the general population. In conclusion, hematopoietic stem cells transplant patients are in high risk to develop oral cancer, and these patients require careful and continuous oral cancer surveillance as their routine follow-up by the dentist. At the end, I want to thank my colleague, Dr. Gupta and Dr. Nikarajun, as well as my mentor, Dr. Aryani, and Dr. Mishra for all their help and support for this study. Thank you for listening, and I'll be happy to answer any of the questions.
Great presentation. Are there any plans for future work on this topic?
Yes, that's a good question. Thank you. Yes, the next step is to consider another confounding factor like history of head and neck cancer, as well as genetic and smoking will be considered in the future. I'm sorry, can you repeat?
Sorry. I'm wondering if you were able to look at the prevalence of human papillomavirus amongst the patients that had oral cancers.
No, we didn't.
That's very interesting presentation. I have a question. So most of these patients are immunosuppressed, right, after the transplant, or did you think about the plausibility, or do you have any scientific hypothesis why this is happening? Why you find an increased risk for oral cancer in this population?
That's one of our next step to look about this immunosuppression, and we're gonna look more in the future.
Great presentation. I'm here. I'm curious to know what were the search terms that you used in Patient Explorer and Immerse? Were they the same, or what kind of codes or query terms you used?
Yeah, we used the ICD-10 code for oral malignancy in the oral cavity. We excluded the other cancer like oropharyngeal and salivary gland cancer.
Patient Explorer is structured data and Immerse is for clinical notes. Were those codes the same, or did you manually, for Patient Explorer, which is a structured data, did you manually indicate the codes, or did you use the SNOMED or SNODENT codes?
So we use the Patient Explorer to get the exact number. Then we collect from Immerse the exact clinical note from each patient manually.
Okay, so you try to find patient first and then take a look at their notes.
Yes.
Okay.
All right, thank you, Abdullah.
Yeah.
Our next speaker is Malik Ahuja, working with Dr. Christine Hong, and he's going to tell us about microRNAs in palatal expansion.
Okay, hi everyone. My name is Malik Ahuja. I'm a D1 here at UCSF, and I did my summer research fellowship in Dr. Christine Hong's lab. My project was focused on the effect of miR-200A inhibition on suture remodeling after palatal expansion. So as many of you know, cleft lip and palate is one of the most common congenital anomalies with an incidence rate of about 1 in 700 births. And patients with cleft lip and palate often require palatal expansion to help them achieve normal speech and functional occlusion. But after expanding the palate, if the bone formation along this mid-palatal suture is insufficient, then the expanded palate has a strong tendency to relapse back. And this post-expansion relapse disproportionately affects cleft lip and palate patients, with over half of them experiencing it. And there's currently no clinical therapy to promote this bone formation and thus possibly prevent or reduce this relapse. However, the results from my presentation today have found that microRNAs, or miRs, could be a potential avenue to address this problem. So miRs are small endogenously produced RNA molecules that post-transcriptionally regulate gene expression, often through this method of binding to and silencing specific genes. And in particular, miR-200A is known to suppress bone formation. And recent studies have found that inhibiting miR-200A using a new plasmid-based miR inhibitor system can promote bone regeneration and alveolar bone defects. But this new approach has never been used in the context of suture remodeling after palatal expansion. So the main aim of this project was to evaluate the therapeutic potential of inhibiting miR-200A after palatal expansion to see what effect it has on the bone in the mid-palatal region. And we accomplished this with the following 3 methods. So first, we wanted to confirm that miR-200A is expressed in the suture. So we collected some mid-palatal suture tissue, palatal bone, alveolar bone, gingiva, and long bones from 2 mice so that we could compare how much miR-200A is present in each of these tissue types. And surprisingly, we found that miR-200A was expressed the highest in the mid-palatal suture by a pretty significant amount compared to the other tissues, meaning that it could play a pretty important role in suture remodeling after expansion. So to explore this potential effect in vivo, we used our lab's tried and tested mouse palatal expansion model. And I'm happy to answer any questions about this method during the Q&A, but as a brief run through of the procedure, we applied these manually wire-bent palatal expanders in 6-week-old wild-type mice. And this expander is self-activating, so it gradually expands on its own, exerting 40 grams of lateral force from this central helix to expand the palate. And so the mice had their palates expanded for 7 days, and during this we injected them with either a control vehicle or the miR-200A inhibitor right above the anterior palate, like you can see here. And so after 7 days of expansion, we converted the expanders into retainers by putting composite over the helix so that the expansion force was deactivated, but the space created by the expander was still being maintained. And here you can see what the retainer looked like in vivo. So after expanding the palates, injecting the inhibitor or a control, and allowing for 1 week of retention for the bone regeneration along the suture, we micro-CT scanned their skulls to analyze the anterior palatal region right between the incisors, as you can see here. So first, we wanted to verify that our palatal expansion was successful, so we used the micro-CT scans to measure the palatal width of each mouse, and this is an example of what an unexpanded mouse palate looks like. And in comparison, here's what our expanded mouse groups looked like. So we found that the palatal expansion did occur successfully in both of the groups, and it was also a pretty consistent amount of expansion across the experimental and control injection groups. So after confirming that the expansion was consistent and successful, we wanted to compare the quality of the bone in this palatal region to see what effect the miR inhibitor had on the bone remodeling around the suture. And so from the bone quality analysis, the miR-200A inhibitor group had a higher bone volume in the expanded region. It had an increased bone mineral density and a reduced trabecular separation. So essentially, these mean that the group that was injected with the miR-200A inhibitor not only had more bone in the anterior palate, but the bone was also more mineralized and likely more mature. So overall in vivo, we found that inhibiting miR-200A produces an anabolic effect on the bone formation post-expansion in the suture remodeling. So next, we wanted to start looking into the mechanism for how this effect might be happening. Oh, sorry. But before we dive into how we explored the mechanism, just a quick refresher on how microRNAs work again. So miRs inhibit specific genes and decrease their gene expression. So essentially by inhibiting miR-200A, we're upregulating its gene targets because the genes are no longer being suppressed. So we wanted to start narrowing down which genes might be getting targeted by miR-200A and thus upregulated by the miR inhibiting drug. So we used the TargetScan 8.0 database to identify some genes that are normally suppressed by miR-200A, and using current literature, we narrowed the list down to 8 genes with known osteogenic effects. So essentially, these are some genes that might be getting upregulated by our miR inhibiting drug to create the osteogenic effect that we observed in their palates after expansion. And you can see that each of these either promotes bone formation or inhibits bone resorption for an overall osteogenic effect. So in summary, since we found that miR-200A is so highly expressed in the suture and its inhibition in vivo enhanced sutural bone formation, this new drug could ultimately help reduce relapse after palatal expansion with potential to improve outcomes in patients with cleft lip and palate. However, before we get to that point, a lot more work needs to be done. And here are some of our more immediate next steps. But in summary, even though these are early results in mice, this project definitely lays the groundwork for exploring miR-200A as a therapeutic agent in palatal expansion. And I'd now like to take a moment to thank my mentors for dealing with all of my questions this summer and the other dental students that helped to complete this project with me. And a few additional acknowledgements to the Ament Lab, Dr. Behrens and Roger for supporting me. And here are some references. And thank you guys so much for listening. All right, questions? Yeah, Erica.
Oh, hello. Amazing job. That was really cool. I was actually wondering, would you be able to talk about like when you injected the mice and like why did you pick those times?
Yeah, that's a good question. Let me go back to the slide with our timeline here. So you'll notice that we injected it on 3 separate days, and the days might appear kind of random. But so essentially, in one of our previous studies that involved this same palatal expansion model, we found that the bone remodeling peaks 3 to 7 days after starting retention. So around from this day 10 to 14 is when the bone remodeling peaks. And we wanted to make sure that the drug was present before the bone remodeling peaks, because mirrors have a somewhat indirect effect. And also, we really wanted to make sure that it was there during the peak bone remodeling.
Hi, so I was just wondering how you put the expanders on the mice.
Yeah, that's a really good question. I will say it's quite the exercise in manual dexterity. It was especially rough since I'm a D1, so I haven't really practiced my manual dexterity that much until this. But so essentially we start by anesthetizing the mice with ketamine and xylazine. So they are asleep, which makes it a lot easier. And then we pretty much prop their mouth open using an apparatus that looks like this, or I'm sorry, right like this. Or actually, no, it's in this one too. Yeah, so we prop their mouth open, they're asleep, and from there we use pretty much forceps and a perio probe to get it in the right position. You put the flowable composite on there, and you wake the mouse up, yeah.
Thank you.
Any more questions? All right, let's thank Malik.
Thank you, guys.
For a great talk. And our last speaker for this afternoon session is Roa Sadeh, who's working in the lab of Dr. Elizabeth Mertz. And she's going to tell us about the impact of COVID on enrollment in Medicaid programs.
Thank you.
Thank you.
Awesome. Well, it's a privilege to speak here today. I will be continuing the research that I left off on when I did my pre-D1 research fellowship. So the topic for my presentation today is the impact of the COVID-19 pandemic on dentist enrollment in the Medicaid program in California. So as many of us are aware, Medicaid is a public health insurance program for low-income adults, children, pregnant women, elderly adults, and people with disabilities. The largest share of individuals covered by insurance is covered by Medicaid. California in specific has coverage for both children and for adults, and this is not the same for many other states in the United States. However, one thing to note is that although we do provide coverage for adults, it isn't always utilized, and dental providers not always have this as an option for their patients. So in this research paper, we really wanted to examine the impact of how COVID-19, which brought a lot of disruption to the workforce in terms of how dentists were able to utilize this. We looked at many different types of demographics amongst providers, and we really hope that this research will inform policy approaches so we can do a better job. From the previous research, we saw that there was a significant impact in fee-for-service and federally qualified health centers in terms of adult utilization. And the impact was immediate from COVID-19. And we did see a discrepancy in fee-for-service, in which there's fees associated with services, and federally qualified health centers that are there to be a safety net for our populations. So we will see in just a bit if, similarly to how we provide care for our adult patients, if, how can we similarly compare the trend for dental providers? So the specific aims are two. Number one, to quantify and model enrollment of dental providers in Medi-Cal, in which I define as serving over 100 adults patients in a 12-month period, and also to examine in further detail the provider demographics and population served. The methods used was an analysis of Medi-Cal dental provider enrollment from 2014 to 2021. More specifically, I test the COVID-19 pandemic reduced the number of providers serving Medi-Cal adults, and also non-federally qualified health centers were more likely than federally qualified health center providers to reduce these services, in similarity to what we examined in the adult populations. So I developed multivariate regressions with interrupted time series model, and also a generalized estimating equation with zero inflated and mixed models, which we'll see in just a moment. So overall, we saw that Medi-Cal provider participation climbed steadily, as we can see in the first chart above, and we did see a noticeable dip in 2020 during COVID-19. However, we did see a little bit of a rebound in 2021. Overall, as we can imagine, general practitioners consistently represent the largest share of providers serving most of the Medi-Cal adult populations, and we saw it increase from 15% to almost 20% from 2014 to 2021. That's good news. In addition to that, we saw that registered dental hygienists with expanded practice did decrease, which we will talk in just a moment. Specialists had a moderate increase, and overall we can see that there are some varying dental providers that provide different services for the patients. Some significant points to mention is that overall, as a result of the pandemic, we saw that providers were at 15% higher odds of leaving Medi-Cal compared to 2014, which has a really big impact on the workforce stability. In addition to that, younger dentists were more likely to leave Medi-Cal compared to their older counterparts. Registered dental hygienists had a lower odds of leaving Medi-Cal, and then the highest patient count that were served by dental providers, we saw that dentists were less likely to leave Medi-Cal by the greater number of patients that they served. And also we examined that federally qualified health centers had a lower attrition risk. So in these models, we can see that there was a reduction in the COVID-19 pandemic in terms of utilization. We see varying amount of utilization amongst the different counties, with specifically federally qualified health centers maintaining a higher utilization rate overall. Now, from the different points that we mentioned, we did note that when dental providers were serving around 500 patients, the rate of leaving Medi-Cal reached 80%. So the predicted probability of leaving Medi-Cal reached 80%, which is, concerning. But when they saw 500 patients, the probability of leaving approached 0%. So this makes us think about the policy implications of setting standards for how many adult patients that Medi-Cal providers can provide and continue their care. In conclusion, we saw that the COVID-19 pandemic contributed to decline in Medi-Cal dental provider participation, and we really want to work on informing policy approaches for the future to see how we can retain our dental providers that are providing a safety net for many of our populations that rely on the safety health networks that exist. We see some trends, as I mentioned, from the young adult populations. Our younger dentists are less likely to take on Medi-Cal. We really want to see a change in that because we want to see all of our services being supportive of the general population of California and beyond. Over here I have my references, and then I just want to acknowledge my faculty mentor, Dr. Mertz, who wasn't able to make it today, and her team. I thank everyone for all the help they provided in making sure that we got the data. So I'm open to answering questions. Thank you.
Hi, great study. Was there a reason why you chose the specific period of 2014 to 2021, or what was the significance of that period?
Yeah, so this research presentation narrowed specifically on the COVID-19 effects, before COVID and after. We really wanted to focus on policy impacts with things like Prop 56, the dental initiatives, DTI 1 through 4. So I wasn't able to go into more details of the various policy changes that have taken place in the state, but we did specifically focus on 2014 for those reasons. And in a future paper, we will go into more detail regarding that.
Okay, and then in your general study, did you take into account the fiscal and economic implications of the pandemic in your work? Did you take that into account?
Yeah, so all the data that we received was from all the Medi-Cal claims that were submitted and provided and is served in the state registry. So we took into account, the amount of money that was billed out for the different procedures. Of course, during the pandemic, we saw an increase of ER cases, very dissimilar to how, dentists took on a lot more elective procedures prior to then. So really a lot had changed.
Thank you.
Yeah, of course.
This is a very important topic, so thanks for looking into it. There was also that Medicaid, was that expansion or something during COVID that they opened more enrollments for people. Did you look at the people enrollments too, or just community enrollment, or just the dentist? Yeah. Because the ratios, right? If the dentist goes down and the people go up, There was a lot. And we noticed in our school, at UK, we did internal data, and we noticed a lot more surgical procedures and a boost about 3 to 4 months after COVID when the clinics reopened. A bunch of emergency Medicaid, emergency procedures like urgent care procedures like extractions and stuff like that would be really cool if you looked at the types of service also pre and post, because we saw a huge increase. So did you look into that?
Yeah,
or maybe
absolutely.
I missed it, sorry.
Yeah, no, so that was actually the research presentation that I gave in my first year, in which we examined the impact of the COVID-19 pandemic on just the adult utilization versus the focus on the provider. As you mentioned, there was a very large increase in ER procedures. However, when I interviewed different dental public health leaders, we still saw a lower utilization rate as compared to pre-COVID and post-COVID, because a lot of the reasons they cited was just because of the hesitancy to seek care. There was still a lot of uncertainty with the risk of transmission, and also a lot of federally qualified health centers that provide care for patients front line didn't have the supplies to continue operations. We saw there were very drastic changes in terms of which clinics were given priority for things like PPE. We saw that people just weren't willing to dedicate as much time and effort to make sure that our federally qualified health centers had the resources they need to excel. There's a lot of great trends that we noticed in terms of the centers that did it right, but there's also a lot of work that can be improved. Yes, yeah, and a large part of it can be attributed to just the mandates for non-elective procedures. Yes.
Got one more question in the back.
Hi, I was just wondering, in terms of the FQHCs and the future, for future studies, would you be looking at, the policy that is going into place basically starting next year and seeing how that will affect how your study focused on the providers and their shift towards leaving Medi-Cal and shifting maybe into fee-for-service or things like that?
Yeah, so we definitely are at a point in which we may expect to see a lot of changes with Medi-Cal specifically and the resources it offers for its adult patients. There have even been talks about our own patients that we serve here at UCSF School of Dentistry. So hopefully we can continue the work of examining the trends of patient utilization, provider utilization, and just use all this information that we have to better inform policymaking decisions.
All right, thank you, Roa. And let's thank all of our speakers from the afternoon session. Really interesting talks. So thank you all for your preparation.
Okay, you can see the slide behind me, right? It is open for the People's Choice Award. Please do participate. Vote for somebody that you love. You can't vote for Jeff. So he hasn't done it yet. It hasn't started. Well, let's wait for a moment. It will be starting very shortly, and it will be open until 3:15. It's open? Great. So 3:15, and then it's done, and Roger will be happy. Okay. So let me just introduce Jeff. You're gonna. So let me just put this down.
Share.
Okay.
Laptop.
Okay.
There or not, I'm gonna need my slides.
I think, are we done with the QR code? Did you, hopefully, it hadn't started. It hasn't, it's not started. Do you still need the QR code? Yeah? Put it up, one more time for the QR code.
How do I go back? You got it?
Okay. This is it. Use that QR code. It's going to go off in another 30 seconds. It's live now. Okay. I think everyone's got it now. I hope you have, otherwise you can't vote. Okay, we're going to move on to our faculty researcher, lecturer at UCSF School of Dentistry, Dr. Jeff Bush. He's one of my all-time favorite people. I started actually 1 year after him, so he was my mentor, and he was terrible. I'll never forget it. No, he's a wonderful mentor, and he's been a wonderful mentor to many, many others. So he's the chair of my department of cell and tissue biology. As I said, I've known him for about 12 plus years now. So, but you know, of course I didn't know what he was doing in his PhD. His PhD he did at the University of Rochester. Hopefully some of you know that, where that is. It's an important university, sometimes. And he did his work on cleft palate and cleft lip. So you've heard a couple of talks here today about that. Then moved on to his postdoc at Mount Sinai School of Medicine, and he focused on this efferents. So I think he will discuss some of that, so I'm not going to go into it, but he was elucidating their role in axon guidance and craniofacial morphogenesis. So then he stopped being on the East Coast. He flew out here and he began his lab in 2011. And he's dug his heels a little bit more into the efferents because he can't help himself, and he was working on the shape of the lip, not how big your lips are, thank you, ladies and gentlemen, but on the shape in general. So he's dipped in a whole bunch of different research areas, and he's going to be talking about that. The trachea, the esophagus, he stayed up in the neck. Let's not move away from the head neck, people. And he has performed at such an exceptionally high level. So he was awarded a few years ago the Sustaining Outstanding Achievement in Research by NIDCR. There's only about 3 awarded per year, and so he was one of the recipients of that. And so I want to congratulate Jeff on his fantastic career to date and welcome him to the podium to give us a lecture on his work and himself and his present and his future.
Thanks very much, Sarah. Really appreciate it. Thanks to everyone for being here. Really appreciate the award. I also appreciate you as a colleague and a friend over the years. So I'm thrilled to talk about my lab's research a bit. This somewhat strange title, I can't see almost anybody. This strange title, coming together and splitting apart, I'm going to try to give an overview of what we're doing in the lab currently. I'm going to give a little bit of historical perspective on what we've been up to, but really focus on current projects and just give a little bit of an introduction to each of those projects. And this is the best I could do with a unifying title that kind of covered it. And I hope by the end of the talk, you'll understand why we're going to be talking about coming together and splitting apart. So in general, my lab is super interested in the cellular and molecular basis of morphogenesis. And when I talk about morphogenesis, I'm talking about tissue shape changes during development that lead to the stereotyped shape and form and function of a human. You'll see that we study mice pretty extensively, and I'll try to convince you that there are good reasons for that. We're interested in morphogenesis broadly, but we do quite a lot of work in craniofacial morphogenesis. And if you care about three-dimensional tissue shape changes, if you care about how tissues form, how they come together, there's really no better place to study this than in the craniofacial complex. So this is a movie from the BBC. There's a documentary you can find on YouTube if you're very bored. That really nicely captures the dynamics of craniofacial embryogenesis. Oops. So this is based on ultrasound images throughout human gestation. It's a dramatization. This is not an actual embryo developing. And what I hope you can see is these dynamic tissue shape changes that occur. You see the growth of different craniofacial prominences. You start with this sort of bulbous blob-like thing, and through this process of tissue fusion, tissue growth, cells are moving, new progenitor cell populations are being established. you ultimately end up with this thing that looks sort of like a human face, or maybe a communion alien or something. Again, if you're just interested in the fundamental question of how is a human built, this is a great place to ask questions about that. But there are also really practical reasons to care about this process. So it turns out this process goes wrong relatively frequently. We've heard quite a bit about orofacial clefting today, and I'm not going to spare you from hearing more about it. But in general, structural malformations are relatively common. So about 1 in 40 newborns have some kind of recognizable abnormality at birth. And actually, this is the leading cause of death for infants in the first year of life. So they're an important public health issue. Craniofacial malformations are common. About 3/4 of all malformations found at birth have some component of craniofacial dysmorphology as part of that condition, such that there are more than 700 different craniofacial syndromes and more than 500 syndromic forms just of cleft palate alone. And cleft palate is a relatively common occurrence in humans. I would argue that over the last 30 years or so, human geneticists have done a really good job of identifying candidate genes, gene variants, that are candidates for being causative to various craniofacial conditions. But even so, estimates are only half or so have some genetic component identified. And that kind of speaks to the fact that these craniofacial anomalies are extremely heterogeneous. And what do I mean by that? Well, first off, in terms of severity, so we range from something like an isolated cleft lip or an isolated secondary cleft palate, which is a hole in the roof of the mouth, up to these more syndromic conditions like craniofrontonasal syndrome, which we'll talk about, and Treacher-Collins syndrome, which have multiple organ systems, multiple structures affected. And in terms of etiology, in some of these cases, they're Mendelian, single gene syndromes, but in many cases, they involve gene-gene interaction or gene-environment interaction. And I think one of the very exciting places in this field is how are gene and environment interacting and how can we impact that to prevent craniofacial anomalies. But fundamentally, the thing that we're interested in the lab is understanding the mechanisms that underlie these craniofacial abnormalities, and really at a cellular molecular level, really how do they arise? Okay, I thought this would be a slide of interest for this audience. So, structural malformations in general and craniofacial malformations specifically are really one of the only classes of disease where there's not a single medicine. It's really all surgical. And you can imagine that craniofacial malformations like the images I've just shown are really impactful. So they impact feeding, breathing, speech, vision. In some cases, there are anomalies to skull development that affect brain development. Secondarily, psychological impacts from differences in appearance. And treating these conditions involves a team of specialists with many different specialists. Plastic surgery is involved, otolaryngology. We heard a talk earlier about orthodontics, the importance of orthodontics in palate expansion and other places in treating cleft lip and palate where orthodontics is important. Speech pathology, for sure, a super important one. So in general, diagnosis of these conditions can be made as early as 16 weeks during development. That's by ultrasound. And it's helpful for these conditions to be diagnosed early because then doctors can look for additional malformations that may come along with craniofacial malformations, but also to prepare for the pretty significant treatment course that's to come. So for cleft lip, surgical repair involves 1 to 2 surgeries. Now this is vastly improved over even like 20 years ago or something where you'd expect 5, 6, 7 surgeries. So surgeries are very good, especially for cleft lip. These surgeries are impactful. They start at 3 months of age, so you can imagine your newborn having to go in and get a surgery to repair its upper lip. Cleft secondary palate happens a little bit later, about 12 months. Similarly, 1 to 2 surgeries. But for these more complex craniofacial conditions, many more surgeries are needed. And so I've just put sort of estimates. So for craniofrontonasal syndrome, which is a condition we study, about 5 surgeries is needed for various corrections. Treacher-Collins syndrome, more than 10, up to 20 or 30 surgeries during childhood are needed to repair these conditions, such that I was at a meeting last week and a parent advocacy group referred to it as a surgery every summer during childhood. And that, if like you're a parent, you can think of how impactful that, I don't even think you have to be a parent, that's a tremendous impact on the life of the child. And then beyond that, speech therapy, specialized devices for feeding are a big deal. And it shouldn't be a surprise that the cost of treatment for cleft lip and cleft palate is much higher than for a baby that's born without these conditions. Okay, so I understand, unfortunately, that I'm meant to talk about myself a little bit in this talk, so I'm going to do that. I was born in a smallish town in western New York called Palmyra, New York. About 8,000 people in that town. Very homogeneous. I did not know any scientists when I was a kid. I did not really know that science was a thing. But I guess one thing that, you can see, this is me with my popped collar here. Very cool. It was the 80s. One of the formative things, though, is that, so I have two brothers and a sister, and one of my brothers has a condition called Rubenstein-Tabie syndrome. And this is a syndrome that involves multiple organ system malformations, developmental delay. And so from a very early age, I knew that I was interested in understanding genetic disease. But I didn't really know how or what that would be. I went to Rutgers in New Jersey, and I sufficiently understood that I wanted to study genetics that I enrolled in molecular biology biochemistry as a major, but I have to admit that at that time, I was really much more interested in playing in my band than I was in getting good grades. And that's until I worked in a lab of Mike Shen. So Michael Shen, developmental biologist, cancer biologist. And in that lab, I did in situ hybridizations where I was able to look at the expression of various genes in the developing embryo, mouse embryo, even then. And that blew me away. Like the idea that you could actually look at where genes are acting during development, I thought was extraordinary. So I went to graduate school. I'll talk more about that in a second from a scientific perspective, but I went to graduate school in Rochester. That's where I met my wife. That's her, Nancy Ann Oberheim. She also works at UCSF. She's a neuro-oncologist here. And yeah, this is us when I was a graduate student, believe it or not, ravages of time. And then much after this, we've had three wonderful, very busy kids who are into science as well. We won't tell EH&S about this. And just recently succumbed to getting them a dog. Okay, so just to talk a little bit about my PhD work. So as a PhD student, this was a time where mouse genetics was really gaining serious traction as a developmental system. It was kind of the conditional genetics were just coming online, and there were all kinds of new tools for understanding gene function in mouse embryos in a mammalian organism. And so I was really excited about that, and joined the lab of Rulong Zhang, who was a young assistant professor at the time. He's held up a lot better than I have to admit. He looks pretty much like this today. So I got really excited about this project of positional cloning this classical mutation called Dancer. And Dancer is a mutation that arose spontaneously in the Jackson labs in the 1950s. And it was called that because mice were identified to do this really, we don't need that. This really characteristic dancing behavior. They have a vestibular defect, and so they toss their head around. That's my dancing. And so that was identified. And then when these dancer mice were intercrossed to generate homozygotes, they realized that those mice had a cleft lip and cleft palate phenotype. And at the time, actually, there was no mouse model of cleft lip or cleft palate in mice. And so that was an exciting opportunity to try to learn about the genetics of clefting. And so I stared at dancing mice for 4.5-ish years, and then did a bunch of molecular biology to try to map the mutation that caused this dancer phenotype, and ultimately identified it as a gain of function of the TBX10 transcription factor. So TBX10 is normally only expressed in the brain. In heterozygotes, it has this intermediate ectopic expression where it's found everywhere else. And then in homozygotes that have this cleft, it has this really strong overexpression. So I guess the point is, that was a long time looking at these dancing mice to identify one gene involved in orofacial clefting. And even now, our mechanistic understanding of this situation is pretty limited. So then I wanted to go on and do something a little bit different from a sort of approach perspective. I joined the lab of Phil Soriano, who was at the Fred Hutch Cancer Research Center in Seattle at that time, and got really interested in this disease called craniofacial syndrome, which I've now mentioned a couple of times. And craniofacial syndrome is a condition that affects multiple aspects of skeletal development. So these patients have frontonasal dysplasia. They have a depressed nasal bridge, so they have a sort of shortened midface. They have craniosynostosis, which is a premature fusion of the bones of the skull. They have cleft secondary palate. They also have some axial skeletal malformations, limb malformations, and some neurologic malformations, specifically the corpus callosum, which is the major interhemispheric axon tract. There's agenesis of the corpus callosum. It's lacking in CFNS patients. But the thing that interests me about this condition particularly is that it was an X-linked condition, but actually heterozygous females were severely affected, whereas hemizygous males were mildly affected, and I'm going to tell you more about that in a second. We, in Phil's lab, generated FRNB1 mutant mice and showed that the mouse recapitulates really almost every aspect of the human disease. In fact, actually, I'm saying this a little bit backwards. It's actually the mouse phenotype that enabled the identification of FRNB1 as the mutant gene in craniofacial syndrome. So I'm going to come back to this unusual severity in a second, but as a postdoc, I was really interested in understanding the signaling functions of FRNB1. So FRNB1 encodes a signaling protein. It's it's a transmembrane protein found on one cell, and it signals to neighboring cells that express this other signaling protein called FB, which is a receptor tyrosine kinase. I'm not going to go too deep into any of the sort of molecular mechanism here, but a little bit. So one of the very interesting things about the signaling system is they have the capacity for bidirectional signaling, so they can signal into the cell in which the efferent is expressed or into the cell in which the F receptor tyrosine kinase is expressed. So I wanted to ask which of those is important for what phenotypes. So to do that, I used ESL targeting in mice to generate specific mutations that would perturb just the reverse signal and leave the forward signal intact. And when we did that, what we found was very interesting. We could decouple these different phenotypes. So loss of reverse signaling resulted in agenesis of the corpus callosum, just like the null mutant. But the reverse signal is not important for the cleft secondary palate phenotype. So you can see, hopefully, there's a sort of opening in the skeleton here where the secondary palate should be, and the delta reverse just looks just like the wild type. So it suggested that FRNB1 distinct aspects of its signaling function were important in distinct ways in this disease and in different contexts in development. Also argues that this really has to be studied in development because you need the context to understand where these functions are occurring. Okay, so then in 2011, I came to UCSF. I feel like now that I see this question mark is a little foreboding. I'm not sure that was a good choice. But I have to say UCSF's been an amazing place for me. I feel like there are just people that are experts in every possible field at UCSF. You have the opportunity to interact with them. They're down to earth mostly, and really eager to collaborate in most cases. I want to particularly, so I try to list a few people that I've interacted with a lot, colleagues that have meant a lot to me over the years or where we've had longstanding collaborations. But I can't name everybody. I'm sure I've missed people here. And I also really want to particularly highlight Diane Barber and Ophir Klein. So they actually recruited me as a team into the cell and tissue biology department and the program in craniofacial biology. And both of them have been outstanding mentors to me over the years. So Diane has been a scientific mentor and a career mentor. Diane, I don't know, have no idea how many grants or papers you've read of my lab. So I'm really grateful, Diane. And Ophir's not here, but I'm also very grateful to him. Also, recently in getting the opportunity to serve as a CTB chair, have really appreciated opportunities to learn about how the university works and actually learn some things I never would have hoped to have learned. And really grateful to the administrative team, Dean Reddy, Una Stevens, and the other chairs, and particularly the CAO of CTB, Katie Caddis. That is an ongoing journey to understand all of that stuff, but I've really appreciated all of those people. And now the most important slide of the entire talk is to acknowledge the people that have been in the lab over the years. So have had, I'm not going to name everybody or list everybody, but I just want to point out a couple things. Have had just an amazing group of people from many different programs, DDS, OCS, BMS, DSCB. So really from a wide variety of programs, had great postdocs as well. And these are the folks that have made the discoveries, and really grateful for all of the great work, great ideas, and fun, actually, that they've brought. And here is some of that fun. I cannot argue that our lab has an abundance of party activities. We try, but we have had a great group of people and who've been willing to do adventurous things like skiing and hiking and trampolining. That's Luke up there, by the way. Nice job, Luke. Yeah, I couldn't walk for like a week after that day. I also thought it would be a good opportunity to highlight this remarkable DDS research program that we have here in the school. So this is a list of the students over the years that have, it's probably partial, I don't keep great records, of DDS students who have worked in the lab either for summer research or for year-long research programs or in whatever other way. And particularly just to highlight the efforts of Roger Mraz, who hates it when anybody says anything about him. He's probably not in the room. But I would just want to say, like, this is really a crown jewel, just a precious thing in the school. It's not something that is common to all schools of dentistry, and I think really impactful for labs to have dental students come and do work and get their perspective, but also hopefully to some extent for the dental students as well. Okay, that's enough about me. So now I'm going to kind of tell you about some of the work that we've been doing, and I think the first thing I want to try to convince you of is that mouse models are actually crucial for understanding developmental disease. So the mouse and human genome are very similar. It's about 3 billion base pairs in either case. That's generally true, about 3 billion base pairs in mammalian genomes. There's about 20,000 protein coding genes in humans, 22,000 protein coding genes in mice, so similar numbers of genes. And most of these genes in humans have a mouse homolog or more than one. So 97% of human genes have some mouse homolog, and of those, about 80% of those have a direct, clear one-to-one ortholog where you can figure out exactly what gene is corresponding in the mouse to a human gene. And I think it's important to point out that this provides an opportunity to really study human development in a functional way during development, in a way that you just couldn't have access to in a human embryo. You can study human cells, which is important. You can study human embryos to some extent, or you used to be able to. That's important. But really, if you want to ask functional questions and perturb processes and ask what happens, the mouse model is crucial. Okay, so I'm going to come back now to kind of this craniofacial syndrome that I've discussed before. We were really interested in understanding what are the cellular mechanisms that lead to dysmorphology in this condition, and particularly, why is it true that having one good copy of FMB1 is worse than having no FMB1 at all? So just remember your X-linked genetics. You know, a female has 2 X chromosomes, a male has 1 X chromosome. This male has a mutant FMB1. He's a brother. This sister has 1 good copy and 1 mutant copy of FMB1, so she's heterozygous, and she has dramatic dysmorphology, but he is essentially unaffected. And the reason for this turns out to relate to X chromosome inactivation. So remember that early in development, one of the X chromosomes is inactivated, leading to a mosaic of cells that either express one of the X chromosomes or the other. So in a wild-type situation, either of the X chromosomes is inactivated. Either way, you have a uniform field of cells that are all capable of expressing FNB1, and that expression pattern looks like this in the developing palate. In a heterozygote, if you inactivate the wild-type X chromosome, now you have a mutant cell that has no FNB1. If you inactivate the mutant X chromosome, now you have a wild type cell. So it's really a mosaic of cells that either have FMB1 or don't have FMB1. And what happens in that situation is that the cells actually sort out. And I'll tell you more about that in a second. They self-organize based on the expression of FMB1 or its absence and cause this much more severe dysmorphology than if you had no FMB1 at all. So a wonderful graduate student in the lab, Taryn Neathammer, who's the first graduate student actually in the lab, showed in an iPSC model that this was true likely in human disease as well. So these are patient-derived induced pluripotent stem cells, and she was able to show that this cell sorting phenomenon happens in those cells. Postdoc in the lab, Audrey O'Neill, who's an early postdoc as well, wanted to ask this question of, okay, well, the cell sorting thing, what's happening? How does that occur? And so what do I mean by cell sorting? So remember, this is FMB1 in pink, here's FB2 in this case, there are multiple receptors in green. So what do I mean by cell sorting? So this is a uniform field of cells. All the cells have this FB2 receptor, and they're just colored red or green so we can kind of keep track of them. And they move around, they interact with each other, they don't do anything terribly interesting, they proliferate, eventually they'll fill the dish, but don't do anything particularly notable that causes me to keep watching this movie. But check this out. So when we combine cells that express FMB1 together with cells that express FB2, you see something dramatic. Now these cells completely self-organize based on the expression or absence of FMB1. And they sort out into these large patches of cells, exactly like what we see in those patient iPSCs and in the mouse embryos. So the question then is, how does that happen, right? These cells are exactly the same, except for this one signaling protein. How do they self-organize? Well, Audrey showed that there's this very important protein Rho A, or this important pathway Rho A, that's crucial for this cell sorting. And then Abby Kinberg, another amazing graduate student in the BMS graduate program, showed that not only does this cell sorting happen in 2 dimensions in a dish, but it actually causes tissue separation if you make aggregate tissues out of cells, and such that here are cells that are intermixed, and that F-efferent signaling interaction will actually cause them to do a tissue separation or a morphogenesis, a separation of the tissues. Abby also showed how this works. So Abby developed this system to look at how, just simplify everything and put only 2 cells in this small well and ask how 2 cells interact. And in this system, when Abby looked at this, she saw that FMB1 cells, they make strong, stable contacts. Same thing for FB2 homotypic pairs. But now when you put an FB2 expressing cell together with an FMB1 expressing cell, those cells really don't want to make contact with each other. They want to minimize interfacial tension between them. And that is dependent on actomyosin contractility, which we're going to talk a little bit more about. And also, if you inhibit actomyosin contractility through a number of different pharmacologic methods, you can actually prevent this cell sorting behavior, either in this 2-cell system or in a more complicated cell segregation assay. So through that, Abby really showed that this forward signal, which involved Rho A, also involved a change in cortical actomyosin that was specific to the FB expressing cell type. Okay, so that was a couple years ago. So fast forwarding now, we've made a kind of a cool discovery. I don't know if Karine is here, but this is a project, Karine Shamardani of the OCS program, who made this discovery that efferent B1 loss of function actually interacts with another protein called SHROOM4. I'm not going to tell you much about SHROOM4, but I want to point out how interesting this is. You know, we think a lot about single gene Mendelian conditions, but actually most congenital malformations are probably involve multiple genes, right? So we're talking about multiple genes interacting or gene-environment interactions that cause or influence disease severity. So here's a situation where we sort of serendipitously discovered that in the lab. So these efferent B1, sorry, I can't actually see up there. These efferent B1 hemizygotes have a cleft palate with about 33% penetrance. SHROOM4 mutants have 10% penetrance, but now if you have double mutants that lack both efferent B1 and SHROOM4, there's a synergistic effect. And now all of them have cleft palate. They also have severe craniofacial dysmorphology when we do morphometrics to quantify these craniofacial defects. So this is a real opportunity then to understand what is, in this case, the multigenic basis of this craniofacial disease. How do these two distinct genetic insults lead to this more severe disease phenotype? So this F-efferent signaling pathway is a huge pathway of proteins. We are excited about multiple members of this pathway. It turns out that another member of this pathway, which is called efferent B2, is important in cell segregation in a totally different context. This is work that was done by Ace Lewis in the lab, where he discovered basically that efferent B2 loss of function leads to a complete failure of the trachea and the esophagus to separate during development. And that is also a human birth defect. It's called tracheoesophageal fistula, and it can occur in many different sort of specific conditions. It occurs generally in about 1 in 3,000 births. Actually, before I go on, I also want to say a little bit about Ace. So Ace has been in the lab for a long time. I think he joined after 1 year of the lab's existence. And Ace has been just a tremendous partner in the lab in really all things, and just a super creative and technically brilliant person who I've really benefited from working with all these years. So I wanted to make sure I mentioned that before I move on. Okay, so Ace has really focused on asking this question of how does efferent B2 regulate this tissue separation? And what he has shown is that the trachea and the esophagus, which separate through this sort of zipper-like separation that starts at the lung buds and separates the tracheal and esophageal tubes, well, in efferent B2 mutants, things look kind of okay for the trachea, the lung buds look kind of okay, but they just completely fail to separate. And Ace has shown that we think that that is a very similar tissue separation process to what I just showed you in the dysmorphology of craniofrontonasal syndrome, where efferent B2 is regulating a cell sorting process that happens right at the interface of the trachea and the esophagus. That project has also led to this whole other arm of research in the lab where we're excited about understanding the early patterning of the trachea and the esophagus. This is work that was also sort of initiated by Kayla Kuwahara, who is a DSCB graduate student, and carried forward by Marisol O'Neill. And now Ace is carrying it forward, where we're asking a lot of questions that relate to the early patterning of the trachea and the esophagus. I think I'm going to sort of leave it there, but if anybody's interested in understanding how tracheoesophageal development, I encourage you to ask Ace. Okay, so kind of returning to craniofacial development now, kind of change gears. I'd like to focus the remaining time on cleft lip and cleft palate, and I want to tell you about some new discoveries we've made on how tissue fusion happens in these contexts. So tissue fusion is a key part of craniofacial development. It's important for the development of the lip, where these structures called the MNP and the LNP have to zipper closed around the nasal cavity to create the nasopharynx. And then in the secondary palate at later stages, these palatal shelves have to come together. They have to make contact and essentially zipper close to septate the oral cavity and the nasal cavity. And when these things go wrong, that's when a cleft lip arises. So when this MNP-LNP fusion fails, we have this cleft lip phenotype. When the secondary palatal shelves fail to fuse, it results in a cleft secondary palate phenotype. And when both of these things fail to occur normally, both cleft lip and palate occurs. And in general, these are common. When you kind of aggregate, these are relatively common craniofacial malformations. So Luke has already talked to you, so I'm going to go really quick through this part. But Luke Lucido, who's an OCS student in the lab, has been really interested in this part of the process, where the frontonasal mass has to undergo this very rapid and dramatic change, where it invaginates this nasal pit and forms these medial and lateral nasal processes, and that is really required for the ultimate formation of the normal intact upper lip. So Luke told you all about this work, and he's got a really exciting story, but I'm going to kind of move past that and focus on tissue fusion in this process. So what I want to focus on now is this zippered-like fusion that happens between the lateral nasal process and the medial nasal process, which has to progressively close the nasal pit around the nasal cavity, ultimately leading to this small nostril-sized shape. And again, when that fails to occur, a cleft lip results. Want to point out that we're not the only people interested in this fusion event. So Alicia Soleri has done, and her lab has done some really beautiful work on this process, where even several years ago, she wrote a paper that hypothesized that there are many different cell behaviors that contribute to this zipper-like fusion of the upper lip. And she's got a really beautiful project on localized cell cycle arrest in this process. But we have been really interested in asking questions about what are the cell-generated forces that drive this tissue fusion. In general, just to remind everybody that every cell has a cytoskeleton, and one of the important parts of the cytoskeleton is the actin cytoskeleton. These are these large filaments, bipolar filaments, that also bind to non-muscle myosin, and non-muscle myosin pulls on these actin filaments, and through this actin-myosin contractility changes the shape of cells and allows cells to migrate, change tissue shape, do all of these very interesting force-generating things during development. So there are many reasons why we wanted to look at actin-myosin contractility in this fusion process. Turns out that actin-myosin contractility has been studied in similar-ish processes in the past. These include Drosophila dorsal closure, where there's a zipper-like purse string closure of these tissues. In the mouse neural tube, it seems like actin-myosin contractility is very important. Also true in Siona intestinalis, which is an invertebrate. But there's also this sort of actin-myosin zippering that happens. And we've also looked at this in secondary palate fusion. I'm not going to talk about that at all. So Camilla Teng in the lab wanted to look directly at how this actin-myosin contractility is regulating this process. And to do that, she developed a whole new set of live imaging tools. And this was sort of briefly shown by Luke, but I'm going to explain it a little bit more. So what Camilla does is to dissect the midface out. This is a very challenging dissect. These are very small. You're thinking about like something that's, you know, like this smaller than a pencil eraser, smaller by half, you know, something like that. To dissect this out and then put it into a dish, and then with special media, and to actually look at the actin cytoskeleton during this tissue fusion process to see what are actin dynamics like during lip fusion. And so I'm going to only show a couple of her movies. I wonder, can I get the light off? Is that possible? Thank you. But so what we're looking at here, we're focusing on this junction between the MNP and the LNP. And what I want to show you is that even at the start of this movie, you can already tell there's this dramatic enrichment in F-actin right at the interface between those two structures. And as I play this movie, what you're going to see is this expansion, this sort of propagation of these long multicellular actin cables that appear like they're sort of pulling those two structures together. Okay, so that's kind of the first window of lip fusion I'm going to show you. If we look a little bit later, now these structures have already fused to some extent. And what I want to show you is you can actually see these multicellular actin filaments pulling sort of like a purse string to zipper closed those structures, the MNP and the LNP. This is incredible. So these movies, you know, take a ton of work to make, and I find them tremendously compelling, arguing that there's this dynamic actin-myosin contractility that underlies the fusion of these structures. You can turn the light back on, thanks. When you knock out key non-muscle myosin proteins just within the epithelium, it results in a cleft lip phenotype as well. So not only is there this elevated F-actin in that tissue, but actin-myosin contractility seems like it's crucial for pulling together of the lip. Actin-myosin contractility can't work alone. It has to attach to the cell-cell adhesion junctions that connect cells. And it's therefore, and I'll talk a little bit more about these junctions in a second, but it's notable then that mutations in genes that encode proteins that are a part of these adhesion junctions are often found in people with cleft lip and palate. So one of these is P120-catenin. P120-catenin binds to this protein E-cadherin that probably everybody's heard about in cell biology. And E-cadherin is it's a cell adhesion molecule that tethers two cells together in a really dynamic way. P120-catenin binds to E-cadherin and stabilizes it at the membrane. There are these other proteins that I won't talk much about, beta-catenin and alpha-catenin, but I do want to point out that those proteins are crucial for connecting the adherence junction to the F-actin cytoskeleton, and that's really crucial for transducing forces across multiple cells during development. And anyway, back to what I was starting to tell you is that mutations in P120 catenin seem like they're maybe the most frequent cause of non-syndromic cleft lip that we know of. So we wanted to understand better how that worked. Turns out that P120 catenin has multiple functions. So one of its functions is, pardon the early lightning bolt. One of its functions is to bind to cadherin and to stabilize cadherin at the membrane. It also actually can bind to RhoA and inhibit its function to regulate actomyosin contractility. P120 catenin can also go to the nucleus and act as a transcription factor to regulate gene expression. So Camilla wanted to ask this question about which of these P120 functions are important. And to do that, she wanted to make mutations that would specifically disrupt P120's ability to localize to the adherence junction, or its ability to go to the nucleus and act as a transcription factor, or for it to inhibit RhoA. So really dissect the molecular functions in vivo. And of course, she didn't do that with lightning. She did that with CRISPR-Cas9 gene editing in a really cool protocol that you should talk to her about because it's really cutting edge stuff. And what she's discovered from that is that she also uses this trick so that perturbation is specific to the epithelium. That's a detail. But what she's discovered is that knocking out the ability of P120 to act to stabilize cadherins at the cell membrane results in a cleft lip just like P120 loss of function does. She's also showed that there's multiple cadherins that are important in this process. So why? So what are cadherins doing? How do actomyosin contractility and cadherins work in this tissue fusion process? Well, we've got a whole story on this, and actually it was just accepted for publication in JCB. Really excited about that. But what I want to show you is just one really beautiful image that I hope will give you, your imagination, an idea of what we think is going on here. So here's this elevated F-actin, which is just here at the junction. It's mostly in the LNP side of the junction. And when we knock out P120 catenin, what Camilla sees is that those cells that have high F-actin, they round up and they become disorganized. And it's really only those cells at that particular position that have that phenotype. Cells away from that junction look fine. So that leads to the idea that cell adhesion is acting as some sort of threshold to resist and transduce the mechanical forces from actomyosin contractility in order to allow actomyosin contractility to pull these tissues together and cause their fusion. Okay, I've got 1 minute. I'm good for it. Last thing I'm going to tell you about is our efforts to make some new models of congenital craniofacial disease, and I'm going to give you one example of this. So when a patient goes into the clinic and they have exome or whole genome sequencing, these are essentially the criteria that are used to decide whether that variant that is identified in a particular gene is considered to be pathogenic, disease-causing, or whether it's uncertain significance or benign. And I think if you just review these criteria for a moment, you'll find that they're insufficient. Particularly, strong evidence involves knowing whether there's functional studies that support a damaging effect of that variant. We don't have that for most variants identified in whole exome or whole genome studies. So there's this huge gap in our understanding, and even for those where we think we do have a functional experiment, we're talking about cells in a dish or fly genetics or something, really not context relevant. So there's this huge gap in sort of understanding the functional significance of variants that are identified in humans. So Yungu Zhang, who's a postdoc in the lab, has taken this approach to use gene editing to generate variants in genes where we just don't understand what they're doing, but we think they underlie human craniofacial disease. Here's one that's really exciting. It's called Kalamansky syndrome, and Kalamansky syndrome involves a cleft secondary palate. They have retrognathia, so they have a smaller mandible. They have airway problems because of the small mandible. They also have limb malformations. This thing is, it's called DTDP glucose 460 hydratase. It's been studied in bacteria, and it's involved in cell wall synthesis. That doesn't tell us a lot about what it's doing in mammals, right? We don't have cell walls. So we've been really interested in understanding how does TGDS function in this disease. Okay, so how is Yungu going about this? Well, he's generated mutations in mice to generate tools to dissect context-specific mechanistic function. So when he knocks out TGDS completely, he sees embryonic lethality at mid-gestation, but when he makes this patient-specific gene variant Now he can recapitulate the disease phenotype. So they have cleft secondary palate, they have a smaller maxilla, and in some cases have smaller mandibles as well. That's cool, so we can mimic this human disease by making the same mutations in mice. But cooler than that is now we can use those mouse models to ask mechanistic questions. So what Yungu has been doing is using metabolomics, which is a mass spec-based approach, to identify metabolites that are different in these TGDS mutants compared to the controls. And he's discovered this whole function for TGDS that's completely previously unknown. Also provides some really promising, exciting ideas about how you might be able to modulate disease severity through changing diet. Okay, so just to summarize. So, you know, from the first slide, I showed you my dancing mice, and then kind of where Camilla is with looking at actomycin contractility and lip fusion. I hope I've convinced you that over the last several years, huge advances in mouse genetics technologies, gene editing technologies allow us to dramatically advance our mechanistic understanding of congenital disease. Oops. So what have we cured? Nothing. There are major barriers to therapeutic interventions. These things happen extremely early in development, often before the mom even knows she's pregnant. Often these pathways are important in multiple different processes during development. So if you tickle them in a therapeutic way in one system, now you're going to cause some other problem secondarily. So there are huge problems with that. And I told you also, you know, there's this large class of diseases where they're actually multigenic. They have many genes that contribute to the dysmorphology. So what do we hope for here in that light? Well, I think there are a couple of things that give me a lot of excitement. One is gene-environment interactions. So we know that genes, particular genotypes, interact with, for example, diet or embryonic exposures to teratogens, and are absolutely crucial for modulating disease severity. And that's particularly exciting for metabolic pathways like TGDS that I told you about last. There's also this promise on the horizon for in utero gene editing as a therapeutic. There are some early examples of how that can be done. This is still a little bit of a dream, but I think in probably maybe your lifetimes anyway, like we will be doing this. I also want to make the argument that any sort of regenerative biology approach that involves ES cells in a dish, whether you're trying to make a tissue or make a new, anything, is going to absolutely require a complete mechanistic understanding of the pathways involved in development. So that foundational understanding is crucial. I also just want to, my last words, remind everybody that NIH is really the main source of support for this kind of work. So as you hear in the news about threats to the NIH, I would really encourage you to contact your representatives and advocate for NIH to continue. Okay, so I'm going to just end and put my acknowledgement slides up here again. I hope I've acknowledged everybody. Again, have a really amazing lab and grateful to be here at UCSF. And if I haven't gone too far over, I'm glad to take a question.
Dr. Barber, the floor is open if you would like to ask a question. But Dr. Barber, do we have a...
Really beautiful work, Jeff.
Thank you.
And, you know, for those of you who don't know, when I was department chair, Jeff was my first faculty hire. And
very, very grateful.
I haven't regretted it for 1 second. And what stood out with Jeff compared to 150 other candidates who had applied for the position is that he was really tackling a mechanistic understanding of early development. And you followed through beautifully. So I have a very small question.
Okay.
In one of your slides, where you had pink and green dishes, thanks to all the colorblind people that know those are the colors we're supposed to use now.
That's right.
So to prevent segregation, It looked like you had the ROCK inhibitor and the phospho-MLC inhibitor.
Yeah.
Do you need them both?
Both have an effect independently, but Abby got really complete blockage of segregation when both are used. Suggests that there are multiple pathways leading towards actomyosin contractility, but that it's actomyosin contractility per se that's really having the effect and driving segregation. And Abby did a whole series of very cool washout experiments as well, where if you take those inhibitors away, now all of a sudden they can segregate as well. So the presence of those inhibitors is preventing their segregation over time. So yeah, it is definitely an actomyosin-driven process. We are still looking for the transduction between the F receptor and actomyosin contractility.
I would think that since Rho kinase is upstream of phospho-MLC, that blocking
But also
that
parallel. So they can also be activated independently. Yeah. Or it could just be a more complete effect. That's possible as well.
So I was I was very curious. I mean, I loved it, and I know nothing about this, but I was really curious at the very beginning when you spoke about the X-linked genes and how they affect the presence of craniofacial defects, and then the heterozygous model for the female and then the hemizygous in the male. And all this mosaic appearance in the cell reaction and tissue reaction to this. So I'm curious to understand the evolutionary significance of this. Like,
Cool.
what does this
Yeah.
really mean?
Yeah, and if I had another 4 minutes, I probably would have prioritized more information about that. So that sort of self-organization property of F-efferent signaling, the formation of cellular boundaries and tissue separation, is conserved across creatures and in many different organ systems. So the patterning of the brain involves different F-efferent molecules that sort cells out and cause actually tissue separation in a similar sort of a way. So it seems like a conserved and reutilized way for cells to essentially form organs or boundaries within organs. And there are many examples of that. We're not the only ones who have studied that, but super interesting signaling pathway for those reasons.
So does this mean that females are more, it's easier for based on the model that you show and the mosaic separation?
Yeah, yeah.
When this appears in females, does this mean that the organization of organs or the separation of organs is easier in females than males? I always go there.
Yeah, so well, you want to know why females are better? Yeah, so that situation is specific to the fact that efferent B1 is X-linked and creating these sort of aberrant boundaries during development. So no, that's a pathology. That's a pathological situation. We don't really fully understand what efferent B1 is doing from a boundary formation perspective during development. We have some ideas about it, but we're still thinking about that. Yeah, that's a great question. Yeah. Okay, we're probably...
I think... Oh my God, no.
Sure.
We invited you. That's
fine with me.
Next time, don't. If you're running out of time, you want to get out of here, don't let Shaddix talk. Jeff, this is a fantastic work. I like Effie, I know nothing about craniofacial development, but this is very, very cool. And I'm glad you're doing it, 'cause one of us have to do this. But I worry about the fact that you said that the evidence to support how we determine pathogenic versus likely pathogenic genes. I'm thinking about my exome sequencing results out of my grants that I'm going to do. And I'm like, well, how am I going to call likely pathogenic or not? How am I going to filter these genes out? Help me out here.
Make a mouse. Yeah, no,
Make a mouse.
I think it depends on the context and the exact phenotype you're talking about. And certainly I don't think we need to make a mouse for everything. But for a structural abnormality where we're talking about really a tissue shape change, that's hard to model in cells in a dish, right? So there are things we can model in cells in a dish really well. But I think three-dimensional craniofacial morphology is not one of them, unfortunately. Yeah, that's my opinion. Yeah, absolutely. Yep.
Any more questions? Oh, great. Thank you so much, Jeff. I wanted to give you this as part of our appreciation.
Thank you.
And if you can stand over there and we take a photograph of you. Not with me in it, though. I don't know, I'll put the microphone in my hand. Hold the microphone. Okay, cool. Great, congrats. John Green Society. Amira and Josh. Great.
Okay. Hi, everybody. Sorry. Before we get to the student awards, we just want to be, on behalf of JGS, our student research group, I'm going to present the Mentor of the Year Award. Thank you to all of the mentors who year after year take on the challenge and also are so welcoming and accommodating to all the students and our fellows who join your labs and do great work and learn lifelong skills that propel their careers. This year, our Mentor of the Year is Dr. Akshay Govind. He is unfortunately not here to accept. He's away on a family emergency, so his student, Belle, is going to accept on his behalf.
Okay, so I'm Belle or Isabel. Dr. Govind has been my mentor for the past 3 years, so I've been honored to share a few words from him. He goes, "Thank you to the John Green Society for this very thoughtful recognition, for which I am deeply moved. The Society has played a key role in keeping research a central part of the experience at UCSF School of Dentistry, and Research and Clinical Excellence Day is always abuzz with the energy of intellectual curiosity and diligent effort. The students I have mentored over my 5 years here have made my job quite easy because of their brilliance and hard work, especially when coordination requires fitting into tight windows of time. I know how forever grateful I am to the mentors who helped me figure out my professional course, and it fills me with emotion to know I am able to pay forward that gift to the next generation of oral health professionals. I look forward to hearing about your continuation of this mentorship training."
Okay. We all know what this is. Winners are grinners, people. So I'm going to ask the dean of our school to come forward and pluck out the winners so you can blame him if you are not one of them. The raffle begins. There's 2, so get your tickets out, people. Get your tickets out. Right. Okay, the number is... Are you ready? The number... What? Oh, it's not on? What? You can't hear me? You can't hear that. All right, okay. Well, that's because she hasn't got the number. So it's 096794. Yes. All right. Down. I haven't got anything for you. Go on. Just stay here though. Stay here. Okay, the next number. God, I just did the 794, right? So the next number is 096904. How is that so close to the other one? No way. How is that? How did you pick this so close to the other one? So has anyone got it? Too bad then. So that person, and if you don't have it, here you go, Belle. You pick one. You blame her now. Blame Belle. She doesn't pick the right one. Okay, here we go. I feel like I'm gonna. Anyway, 096847.
Are you kidding me? Do we have to keep going? We have to keep going.
We have a winner.
Oh, great. So, what are we giving them?
They get Amazon gift cards. I'll contact you after the event.
Amazon gift cards. Can you quickly say your names?
I'm Layla Cordova.
And what's a fun fact about you?
I have a dog named Ryder.
Oh, all right. Thank you.
I'm Devansh Sapawadia. I'm a D2, and fun fact about me is I'm in Dr. Knox's lab.
Yes. sorry. He didn't get it for that though. Okay, so the next on the list is the awards.
I think so. What's next on the slide? Yes, awards.
Okay.
Remember, this is where the symbolic.
Okay, so have we got everybody? You got them? Okay, great. It's symbolic.
Guys, if you're a winner, please stay here just to my right, because there'll be a photo with all the winners and our dean once we're done. So, good luck, everyone.
Okay. So I don't know who the winners are, okay?
But I do.
But he does.
We'll start with these
All
guys.
right,
Start
okay,
from
cool.
the top, please.
All right. Okay, the winner, Research Associate category is Kevin Liu. Mentor is Stefan Hablitz. So, Kevin.
Lisa, you get a photo.
Great.
Of all this. Got it? Okay.
If you would just stand over here, please.
Okay.
Postdoc resident category, third place is Dr. Melania Gomez Rodriguez, mentor of the mentee of Hemmerling and Dr. Newhauser. Great. I should shake your hand. Come over here. Second place is Dr. Kushabu Gupta. Congratulations. Come on down. I'll shake your hand too. Why not? Okay. And the first place goes to Dr. Arvind Rajan, who's in Erica Hutchins' lab. There he is. Great. Yes, you've got to want to get down. Well done. Okay, now we're going to go into the graduate category. The third place goes to David Sung, mentee of Oakley Klein. Yes, very unpopular person. So lucky to win this.
D1.
So that's well done, David. Good job. Great job. Second place goes to Christopher Bravo, the mentee of Dr. Susan Lynch. Great job, Chris. First place goes to Hannah Herzog out of the Zhao lab. Oh, and Hernandez lab, I should say as well. So come on down, Hannah. Obviously, you being the first, you've got to come all the way down for the... we are blessed, as you can imagine. So thank you so much. Congratulations. Okay, just a round of applause for everybody here. Okay. So let's just go into the most important prize, which is for the People's Choice Award. All right, are you ready? Are you ready? So the person who is the People's Choice is Malik Ayuha. Yeah, congratulations. So
we're running out of room.
We're running out of room. There's
Go on the piano.
This is it. This is all we can afford on the room.
Okay.
Thank you so much. It was such a pleasure to hear you today. Fantastic.
There's one more of the list.
Oh, hang on. Did I say we had no, we're going to keep going all night. No, the next place, the pre-doctoral category. Okay, pre-doctoral. Third place is Deborah Tan from the Haverlitz lab. Debbie. Great. Congratulations. Second place, guess what? It's Malik again. First place is Ernst Neubrunn. Hang on. First place, no, that's the award. The Ernst Neubrunn Award for Research Excellence goes to Daniel Peruz out of the Momin Harabi lab.
And now we're done.
Is that it?
That's it.
Well done. Thank you so much. Congratulations to you all. Well done indeed. Another year of success. Looking forward to the next one. This was going to be your fake little thing, but this will turn into something real, I tell you, okay?
Very soon.
But you've received my handshake, so you should be very thrilled. Thanks so much. We're going to take some...
Just move off to one side.
Yeah, move off.
We'll
Just go over there.
Don't go far.
We want to take individual and group photos of you. Okay.
I think it's just whatever else left.
Right,
Oh,
so...
People's Choice Award, sorry.
Yeah.
Malik, this is your People's Choice Award.
Yeah.
The local chapter of the AAOCR.
Great. Okay, I think... You know what? We've come to the end. I know you're going to be... Don't cry. Don't cry. I can see tears in your eyes. But there are lots of people to thank. Luciana is one of them. What a great talk. I hope you were here this morning. An amazing talk by our plenary speaker. The clinical speaker today was Diana Nguyen. Fantastic. Of course, the lecturer, the Faculty Research Lecturer Award went to Jeffrey Bush. Dr. Bush, thank you so much. The planning committee for this, thank you. Thank you, planning committee, for planning, and I hope you enjoyed today. The session chairs, Semel Chotsky, Flora Ravi, thank you so much. These guys, John Green Society. Without the John Green Society, would we even have this? The answer is probably not. So keep going and keep attending. We're looking forward to the future with you. The judges. I don't know how we managed to pull the judges out. They're not judging because they love to judge. They're judging because they're interested in what you have to show. And so we're awarding those people the awards, aren't we, that do the best. But thanks to the judges, that's how that happens. Our staff, our student support, all of it, thank goodness. There's a lot of support that goes into this. There's John over here doing his best on the big typewriter. So all of this is able to be seen by you, and I hope you enjoyed that as well. All the volunteers, right? All the volunteers, you don't even know who they are, but they're volunteering for you. So thank you, volunteers, for being involved. And there's no one else but, guess what, the man who does not ever like to be congratulated, but this is Roger Moratz, and he has done it all. Okay, so big... And that's it. Thank you so much.
There's
we'll see.
Reception across the
Oh, yeah,
street.
that's right.